Yes, almost.
So you can see the picture?
Yeah, we can see very clearly.
Hello?
Yes, we can see very clearly.
The Excel film, the view box, you can see?
Yeah, we can see very clearly.
Okay, okay. So this is great for adenoid hypertrophy, and tonsils are also great for hypertrophy.
How you grade these adenoids actually? Radiologically or clinically? What is the criteria?
So clinically, he was having obstructive apneic spells during night and with this disturbance of sleep. And the indication for this patient of adenotonsillectomy is obstructive sleep apnea. And now the indications has been changed recently for last few years. It is the first indication for adenotonsillectomy is now obstructive sleep apnea in kids.
Yes.
And the second indication, as usual, it was earlier recurrent adenotonsillitis. So we are going to start the case.
So can you just show us the patient picture? How you position it?
Pardon? Hello?
Miss, position of the patient, your position.
Position of the patient is tonsillar position.
Good morning, sir. Nice to see you in the morning. Now, sir, we would like to know the settings of coagulator and all this.
Yeah. We will be showing that.
Okay.
For tonsillectomy, coagulation tonsillectomy, we are having the company setting 7.3. And for adenoid, we change the setting to 9.4.
Okay. What is the rationale for this, sir?
Pardon?
Like there has to be some reasoning or logic for all this setting.
Yeah. So we know that coagulation is a plasma-driven technology. So this 4 is 1, 2, 3, 4, 5 is coagulation technology, and from 1 to 9 is this is coagulation technology. So we have to increase the coagulation part whenever it is required. And in adenoid surgery, we usually take 9.4 setting. वो लगा ना हाँ
सर आपने बोला ये स्लीप स्टडी से लिया है तो हैव यू इवैल्यूएटेड द चाइल्ड फॉर स्लीप स्टडी लाइक वेयर एपनिक स्पेल्स या कुछ देखा था कि अपन को क्लिनिकल हिस्ट्री पे वी हैव टेकन दिस
So what about the position of the cube?
हेलो
Hello sir, good morning.
यार इसकी आवाज़ बढ़ाना यहाँ के स्पीकर की इधर ले लो आप
Hello.
हेलो
Hello. Sir,
Yes,
am I-
please.
Sir, very good morning. Udbhav this side. Sir,
Actually, I am unable to hear. Just a minute, we are setting the speakers. इसको इधर कर दे. Hello.
Hello.
Yes, please.
Yes, sir. Very good morning. Udbhav this side.
हाँ उद्भव डॉक्टर
Yes, sir. Sir, what about the position of the tube? Where you keep
position of the patient is like we do routine tonsillectomy. That is the same position.
and the tube position, the tube,
Pardon?
the tube.
Tube position is central.
Okay.
Tube is in the center. You can focus the patient, cameraman. एक मिनट. इसको ऑन कर. हाँ इसको ऑन कर. और ऑन कर. हाँ दे दो यहाँ से निकालो. क्या ना नेक्स्ट केस का है. हाँ हाँ फेस का.
Sir, have you used any shoulder bag or anything?
Pardon?
Sir, have you used any shoulder bag?
Oral pack? Yes,
Shoulder-
yes, we will do. We will be doing throat pack.
Sir, shoulder bag, like
Okay,
behind.
okay, okay, okay. तो मेरे को ना ड्रेप कौन सा है, कट शीट कौन सी है? इसको ऑन कर दे. How is the picture?
Excellent.
So we are using Leica microscope and we'll be using 0-degree endoscope from Smith and Nephew.
Okay.
Cable तो ना ये वाली यार,
Sir,
camera cable.
kindly focus the picture a little bit more.
Okay, okay, I will do that. Just let me know when it's okay for you. It's okay now?
Sir, it can be done even better, I think.
Okay.
So, sir, you routinely
Yes.
do with a microscope, Paul.
Sir, actually, we are seeing the posterior wall more clear than the tonsil.
Okay, okay, okay. Now?
Yes, sir, much better. Yes, sir, now.
It's
Yes,
okay? You
yes,
can
sir.
see the
Now we can see
vascularity of the tonsil also.
Yes, sir, yes, sir. Now it's good.
You prefer doing tonsillectomy under microscope always, or today just for demonstration?
This is more for demonstration purposes, but routinely we can do with simple headlight. So I am also decongesting the nose with cotton pledgets. उसको नहीं करना अभी, चेंज नहीं करना. हाँ. Hello audience.
Hello, yes, sir.
This is the coagulation van EVX 70 with 3 electrodes.
You want to centralize the image, sir? Half
So-
image is coming, like we're not getting the good image. The probe is also not seen. Now we are better.
Okay, okay.
But I think you need to like zoom out, sir, if it is possible.
Zoom out, I can do that.
Not be there.
अब ठीक है?
This is better, yes, better.
Okay. Now it's okay?
Yes.
So,
You have given any pre-medication, or you are going without? The local you have not given?
no, local is not required.
Okay.
So I have just increased one step. Okay. Now it's okay?
So you are going from the right side first?
Yeah.
Okay.
Yes, okay.
Right is okay then.
Right is okay, sir. It's fine.
So this is the normal setting is 7.3 for this coagulation EVX 70 van. उसकी ना वॉल्यूम कम कर दो कोगुलेट और इसका सब बढ़ाओ. चला गया. Can you focus this? So can you see this is the just I'm checking the wand. So after checking, just holding the tonsil as usual, as we do in conventional surgery, pulling out medially. You can see some folliculars. These are visible because it is a magnified picture. So we can start at any point. We can start from the upper pole, the lower pole, or the mid region. Picture is clear? Mucosa over the tonsil? It is already it is already protected. See, this is having the thermal injury is very low, so the healing is quite fast. I am just marking the incision line like this. This is ablation mode. No, we are not touching the mucosa. It is around maybe 1 millimeter away from the mucosa. It is the plasma which is doing the job. See, I am not touching the mucosa. Can you appreciate that? So, yeah, this is the plane. Yeah, this is the dissection plane. Again, we can hold it a bit more and medially. So, this is the plane you can see. Is this clear? Okay. Now you can see the plane and the tonsillar fossa. There is no need to touch any tissue over here. This has to be medially. You can re-hold the tonsil again just to pull it medially. See, there is no bleeding. And this is the routine suction which we are using. We have to be cautious here at the lower pole. And the beauty of the microscope, using microscope, is that we can remove the lower pole quite easily and without bleeding. Yeah, I will do. Yeah. Is it visible? Now? So that's why we are calling it a bloodless technology. See, you can see the vessel here. Yeah? So we have to be away from this vessel. See. Okay, this is the lower pole. See. So again, re-holding the tonsil again. Keep the wand away from the uvula, because many times it comes in your suction port. So this is the posterior pillar. Is it clear? So I'm through. No, no. Thank you, thank you. Nothing required. Yeah. Piece of technology. Peace of mind. Yeah, yeah. After surgery, at least. So, what I am doing now, I am going to the left tonsil. Okay. Uh, I will try to demonstrate this with my left hand, using coblation wand with my left hand because it is more comfortable. No, no, no. This there is nothing big deal in. No, no, there is no need of confusion. Be simple. ये थोड़ा सा तार इधर करना ये बेटा तार इसके नीचे करना बस 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 okay. So now I am holding my, can you position my okay, now am I holding my tonsil, holding forceps here with my right hand and my wand is in the left hand. Again the same, pulling out medially. उनको बोलना यार. So picture is good. Okay. अब आ रहा. So again the same incision line over here with the wand itself. So this is the left tonsil with my left hand. Re-holding the tonsil again, pull it medially. Is it clear? Now in sleep apnea patients, what we are doing when we are doing palatoplasties, specifically expansion sphincter palatoplasty, we are removing the tonsil, the similar procedure with coblation. Hello, Udbhav? Okay, okay. So, during expansion sphincter palatoplasties, we have to pull out the palatopharyngeus muscle from the tonsillar bed. See, there is so many controversies, like we are having varia and posterior tympanoid. It is same with the other technologies also. That is the technique, this is the technology. So it's not the technique or technology, we have to learn everything. Man behind the machine, that is important. Man behind the technique, that is important. again there is a myth over here. See, we have done so many tonsillectomies. The post-op events, they are similar. And rather the technology, you can see there is no blood at all. The blood, there is no ooze at all. Yeah.
If there is bleeding, what will you of coagulation or?
Yeah, then we will use coagulation part.
Okay.
So just to demonstrate, I will do for you now I am using coagulation. Okay. So this is the normal tissue. See. For coagulation, many times you have to touch the tissue to coagulate. But in ablation, there is no need to touch the tissue. The plasma is doing the job. So picture is clear? Now I am shifting to my endoscopes and the position is same. Okay. My position will remain the same as for tonsil. I am using 0-degree telescope. Good morning, Ji.
Why you want to keep the same position? Why not just remove
See,
for adenoid?
why not using?
Why not just remove the shoulder extension for the adenoid?
I will tell you. See, there are 3 ways to do adenoidectomy with coagulation. Just a minute, let me put a catheter over here. We are putting a infant feeding tube just to pull out the pellet outward. You can see the infant feeding tube. This is small. So I am tying this. Picture is clear? No. Let me zoom out. Yeah. So this is the picture. It's clear? Okay. So I am tying this to pull out the pellet. Yeah. See, this is great for adenoid. So we have to be cautious. And for doing adenoidectomy, we have to bend a bit this coagulation band. Are you seeing this? So you have to hold it like this with the 2 thumbs and the index finger here opposite to the thumb. You can bend it like this. Very light pressure. The same one. Now the setting will be 9-4. You can see the curvature. Okay. No char kar dena. Kar diya. So I am switching to this endoscopic picture now.
You are using the same wand for adenoid.
Yeah.
So what recently I have seen is that this wand, UX70 goes off very soon when we are dealing with Day-2 adenoid. So it hardly lasts 1 day. So what's your take on using precise mat in adenoid?
So it's your choice, basically how comfortable you are. Press P. Okay, chalo. Just a minute. Yeah, I am standing. Usually my position is sitting, but today I am standing for the first time. No specific reason. So I am putting my scope into the nose. You can see the hypertrophy of the inferior turbinate also. You have to.
Is that you are standing, also standing on the head side of the.
Yeah. So this is the.
You feel that this is difficult.
No. This is not difficult. Let me. No. It is.
Generally, we stand on the, facing the patient.
Yeah. Now I will be using. इसको नीचे कर दे टेबल को जरा. इसकी ऑन वो कर दो उधर ऑन का ऑन है नीचे कर दो. Now let me show you the normal position. Okay. बिल्कुल नीचे कर दो इसको ऊपर करना. Okay, now I am sitting. Your turn. So there are three ways to do adenoidectomy with coagulation. This is the one way. The another way is we can use 0 degree and then we can use 70 degree for through the oral cavity. Saline डालो.
In your practice, how much cases you have won last generally for adenoids?
You can say we can do 2 surgeries if you are having some expertise.
Your hand, you are the most expert.
Two. So you can see the wound here. Hello. See, this is the adenoid. Picture is clear?
Picture is clear, sir. You have to tell us what to start where.
Yeah. Everything I will show you. See, you can see the posterior part of the septum here. Saline डालना ऊपर से. I will show you the normal anatomy first.
And you don't need a accessory section.
No, not at all. See, my trolley, एक मिनट trolley दिखाना यार मेरी. See, my trolley is having only 3 instruments.
That is amazing.
Can you see?
Yeah.
Just 3 instruments, one simple, one tonsil holding, one forceps, and other is this technology.
So brush is to clean the tip of the wand.
Yeah. In case there is so you can see the hypertrophy of the inferior turbinate also, which I am touching. Okay. So what we can do at the same time we can do turbinate reduction also, the posterior part of the turbinate. See, with the coagulation, not coagulation, it will bleed. With the coagulation mode, and just to create more space over here. Can you appreciate? Can you appreciate? This is the posterior part of the septum. Okay. This is the posterior part of the septum. This is also slightly edematous. So we can coagulate here also. Can you see? In the posterior part, you are also having some lymphoid tissue. So many times you have to see, you have to decongest this also, just to avoid bleeding. So this is just to demonstrate. So this is the inferior part, the posterior part of the inferior turbinate. So I am coagulating this and creating more space for me for visualization. No, it is not upside down. It's perfect. So this is the position. You can see the throat pack over here. Yeah. Head of the, at the head. Ye- See, this is, yeah, this is the 12 o'clock. For me, it is the 12 o'clock position where the wand is. Hello? This is the 12 o'clock. This is 6. This is 9. Okay? Pakad. Huh? Is there any confusion over here?
No, it's perfect. You can start, sir.
Okay. So you can see the eustachian tube orifice here. The bubbles are coming out. Right? So this is the lateral end of the adenoid. This is the tubal torus. This is the inferior part of the eustachian tube opening.
Good morning, sir.
Good morning.
Sir, one question, sir.
Yeah.
Will you consider, sir, complete turbinate reduction of abdominoplasty in such case?
No. Just I'm coagulating it just to reduce it. This is turbinate reduction from the posterior part. See, whenever there is obstruction, usually the turbinates get hypertrophied.
So in such a large turbinate, sir,
You can see the adenoids into the, from the nasopharynx into the nasal cavity also. Can you appreciate this? So I will be starting from this, from 6 o'clock position. This is the ablation mode. Picture is clear?
you start from the roof of the nasopharynx first.
Yeah, roof of the nasopharynx.
So generally, you start at the floor so that the blood
See, yeah. See, again, there is methodology can be different, technique can be different, result has to be the same. Can you appreciate? This was the 10 मिनट हाँ कर दो नहीं सुनो इधर ही लगे Can you see the plasma over here? So what we have to do in adenoidectomy with coagulation and endoscopic coagulation adenoidectomy, we will go till the perimarcium, periosteum of the nasopharynx. And you have to be away from the tubal torus also. Yeah, till the periosteum. So now picture is more clear. We have more space now. This part of the adenoid has been removed, which was entering into the nasal cavity from posterior part. Okay. So my movement is horizontal like this, or it can be vertical like this. Okay. From 12 to 6, 6 to 12, or 3 to 9. So this is 3 to 9. See, I am using the same EVEX 71 with 9-4 setting. Yeah, I will come to that. What I will be doing after completing this, I will just brush this area so that there is some fibrosis and there is eversion of the eustachian tube, this tubal torus area. Okay. So this will come medially slightly because of the fibrosis, and this will open up. Yeah. This will open up the eustachian tube orifice. See, again, my concept is again slightly different. For so many years, I haven't done grommet insertion. if there is adenoid hypertrophy. Just doing adenoidectomy with coagulation, we are opening up the eustachian tube orifice, and within few months, the patient is fine with no ear symptoms. Picture is clear? So I am approaching the periosteum over here. No, there is no difference. The procedure is same. See how much space has been created now. So this is the other part, the right side. I'm going from the left side. This is the left side. This is the right side. You can see the yellowish area over here. This is the periosteum. And I am feeling the bone of the nasopharynx. This is the bone. Sir, good morning. Pardon, sir? In both the cases, sir. Good morning. Sir.
By coagulating the medial surface of the toilet, have you ever come across a fatiguous
No, never. I will show you. I will just brush with in the coagulation mode like this. See. Just this much. Can you appreciate this? Hello? So I've just brushed it out so that it gets everted. You can do in every case. So this is the inferior part. From me, it is the for me it is the inferior part, the 12 o'clock position. Yeah. Till now, my endoscope is in place and it's stable, bilkul. It's not moving in out.
But during ablation near the perimysium or periosteum,
Yeah.
it can injure the periosteum or ablate
We will do coagulation mode when we are. This is the passive and ridge area. So when I will reach here, I will switch on to coagulation mode, and will not touch the perimysium over here, the muscle, the passive and ridge area. You can see the yellowish tinge over here. So this is the periosteum. This is the upper limit. This is my lateral limit of adenoidectomy. So with endoscopic coagulation adenoidectomy, we can remove nearly 90 to 95% of the adenoid tissue. This was the posterior part of the septum. Now I am switching to the right side. Okay.
Sir, in periosteum, mucosa is yellowish.
Yeah. Sometimes we come across with slight DNS over here, so many times it's difficult to use 0 degree 4 mm scope. So we switch over to 2.7 mm scope. But I will try to negotiate if I can.
Sir, we can use angle scope throughout.
Yeah, you can use. So I am switching to 2.7 mm because there is slight DNS over here. See, I have done adenoidectomy in 10-month-old patient also because of obstructive sleep apnea. So this is, you can, एक मिनट शोर नहीं मचाओ यार. Can you see the adenoid tissue? Hello? See the adenoid tissue into the nasal cavity.
Did you give any steroid or something like that before?
I think NSS has already given.
Okay.
How much? 4 mg dexamethasone. यार ये पिक्चर इधर ठीक नहीं आ रही, क्या चक्कर है? उधर ठीक है क्या पिक्चर? हाँ, नहीं. कौन सी ट्रॉली?
What is the age of this patient?
कितने एज कितनी है? 4 years. 13 kg, 4 years.
I mean, going by the size of the adenoid, which we could see, was this patient having any middle ear changes?
No, not at all.
Was the manogram was done?
I am sorry, मेरे ख्याल नहीं हुआ है. But there was no ear complaint as such. And TM was normal. So no need of audiometries.
We are pleased to welcome Dr. S.P. Dubey, sir.
Good morning, sir. ये pull करना जरा, catheter pull करना. So I am slightly asking my assistant to pull out the catheter so that cylinder. बस 9-4 पे है. Yeah. Never. No. If there is severe DNS, then we have to switch over to 70 degree. But in kids, usually there is slight DNS or maybe small spur is there. So there is not a problem. 99% I could negotiate the nasal cavity. Ten months. See, that's why I am saying indication has been changed. There is no need to wait according to age. You have to see the patient complaints, the examination part, and apneic spells with sleepless nights. Pardon? Actually, there is so many people speaking now. I could not hear. Suno.
Basically, you start dissecting laterally and make them come in the medial.
Yeah. You need some space, no?
So here and lateral and then the central margin.
Yeah. Meanwhile, Dr. Satish can discuss the MRI.
Sir, we are enjoying it.
Okay.
This is also part of learning.
Yeah. Saline push करना और नहीं उधर से करना. Saline देना. Surinder. So this is the adenoid tissue which was left earlier. You can show the MRI. हाँ बस हो गया मेरा. Okay. लैपटॉप में ही है सारा. So this is the area of fossa of Rosenmuller. Okay. So this is the inferior-most part of the adenoid. If at all there is slight bleeding, we can switch over to coagulation mode, and I will brush again this part. You can see there is a broken electrode over here. So just brushing the again tubal torus area. Okay. यार बैंड चेंज करना पड़ेगा. See again. This whole band is finished, nearly finished because of the grade 4 adenoid hypertrophy and more for this demonstration purposes. Usually we can do 1.5 to 2 cases in one wound. So this is the passive and ridge area. So I will just coagulate this part. This is my lower limit. I can't hear you, doctor. Dr. Satish will show you tomorrow.
After seeing the proprietor, many people use proprietor followed by proprietor, many people use one proprietor, many people use only proprietor.
So it's up to you it's up to you what you want to do, what you are comfortable with. So this is not adenoid. It is the this is not the adenoid tissue, sir. This is the muscle, pes and ridge. I am just creating some fibrosis over here later on. Just brushing the mucosa over this. See, there is no bleeding at all. I am through now. You can see the picture. This is again.
What is the earliest age, that you recommend we go for adenoid or tonsils?
It's again the complaint of the patient, the disturbance in sleep, the desaturation part. If the child is older, more than 6 years, then we can do sleep study also.
Tonsil means just for tonsillar hypertrophy with adenoid. Every means we have done for universal tonsillectomy to give the air passes or with adenoid.
I am not getting you. Actually, your mic is quite closer to it, so there is.
Now it's okay?
Hello?
Now it's okay?
Now it's okay.
Okay. Suppose when obstructive apnea in sleep disorder in children or adults, if you use tonsils or kissing tonsils with or without adenoid, so what to remove the obstruction, would you recommend to go for unilateral tonsil?
No place of unilateral tonsillectomy in obstructive cases.
Can you show the muscle and sleep from the oral cavity?
Yeah, if I will be using the 70 degree, I can show you. So this is the oral cavity. See, this is the oral cavity and this is the palatopharyngeal muscle, which is used for palatoplasties in sleep apnea patients. So what we are doing in sleep apnea, this whole muscle is pulled out, dissected out partly, and the thick part of the muscle is, this is the incision line, the 2/3 portion. See, this hole is 100% up from this is the area where this is 2/3 portion. This is the incision line. We cut the palatopharyngeal muscle here. We pull out and pull out to here, so that there is a space created over here. Okay? So this is the palatopharyngeus muscle. We make a tunnel over here in the palate, soft palate. We pull out, stitch this muscle over here. Hello? So this will create more space in the nasopharynx and the oropharynx area whenever there is lateral collapse or circumferential collapse. Yeah. Okay. Now there is no bleeding, no need of keeping the pack over here. You can see. You can see, okay? 70. 70. आपकी आवाज़ क्रैक हो रही है, आप माइक थोड़ा दूर रखें प्लीज़.
So, to get more space, you stitch both the pillars of the tonsils?
No need of stitching, because only the upper pole is stitched. While doing palatoplasties, especially the expansion sphincter palatoplasty, ESP, what we are doing is we are pulling out the palatopharyngeus and stitching to the, making a tunnel and stitching to the soft palate, that area. After removing the supratonsillar pad of fat, we are stitching that muscle over the, under the mucosa of the peritonsillar fat area.
Other OT is ready?
Yeah, other OT is ready.
Sir, Dhanyavar.
Yeah.
Sir, you doing evacuate that torus to correct brushing that formally method.
Yeah.
You, this technique can use another application of dysfunctions or
Yeah, this can be used if there is indication over there. No, no, I haven't used this. बेटे गाउन देना उनको. हाँ निकाल दिया. उधर केस स्टार्ट कर दिया क्या?
रेडी सर सर डॉक्टर अभय सूद मिले थे ना हमारे डॉक्टर किशन सिंह क्या नाम बताया आपने उनका
Hello. Yeah. Yeah, next case is ready. Dr. Satish will show you the MRI of the next case. She is a lady of 40 years of age, having chronic rhinosinusitis and bilateral nasal polyposis is there. So, Dr. Satish will show you the MRI scans. Yeah. ये इधर है यार, केस इधर ही है. अच्छा कंसोल से पढ़ने करा. ठीक नहीं कैमरा भी तो चाहिए होगा. तो वहीं जाएगा. ये है मास्क. बस ले रहे हैं आप, रेस्ट करो, ले रहे हैं आपको. हेलो. Dr. Satish, where are you? Satish, वो कॉलर माइक वो ले गया. Hello? Okay.
Hello. Good morning, boss. Good morning, everybody. So, what a fantastic start of the day. So, our next case is going to be a case of bilateral sinonasal polyposis. Are you getting any CT picture? Okay, so we have CT scans on DICOM. This is 1.3 mm sections. And as we always discuss, we need to have a complete three-dimensional information of the area we are operating. And that is given best by a fine section CT scan on DICOM, where we can see the dynamic imaging and 3D imaging. We can correlate the CT in every anatomy, every required anatomy in all three planes. You can see here. We can reconstruct. Any single thing you want to see, you can see. See, yesterday we saw the pterygoid process. See the pterygoid process. What happened to the pterygoid process here? Just for example, this is the pterygopalatine fossa. See this. Or let me show you. Yeah. In the axial section. Can you see the pterygopalatine fossa on both sides? The medial part of the this medial part is the pterygopalatine fossa and the lateral one is the infratemporal fossa. We have seen yesterday in detail in the cadaveric dissection. And behind the pterygopalatine fossa is the what? Pterygoid process. See the pterygoid process on this side and pterygoid process. This side pterygoid process is pneumatized. See this. Pneumatized pterygoid process is known as lateral recess of the sphenoid sinus. So this side pterygoid process is pneumatized, which is considered as a lateral recess of the sphenoid. The right side sphenoid is a bigger one. The left side is a smaller one, but the left pterygoid is pneumatized and known as lateral recess of the sphenoid. Is that clear? Yesterday, to extrapolate the anatomy, I'll come to the relevant CT for this patient after this. Yesterday we saw from the pterygopalatine fossa a lot of, anatomy we explored. From the pterygopalatine fossa, behind, this canal is going. Can you see this? This is median canal. From the medial end of the pterygopalatine fossa, this canal is going median canal. And what is this? This is carotid artery behind. This is the horizontal petrous carotid which becomes, this is horizontal petrous carotid which becomes foramen lacerum carotid over here. So this median canal opens at the level of the foramen lacerum. Can you see? That's the level of the foramen lacerum. And that is the sphenoid sinus proper then. So we need to know all this anatomy from skull-based perspective. That's the pterygopalatine fossa again. This is pterygoid bone, this is maxillary bone, this is pterygomaxillary fissure, which leads to infratemporal fossa from the pterygopalatine fossa. Any anatomy endoscopically we discussed yesterday, want to see on CT scan, we can discuss. This is the right time for that. We have 10 minutes for the next case to be induced. So this is the right time to discuss. Yes, sir. Yes, sir. Dynamic view and three-dimensional. Yes, sir. Very, very relevant question. Come from the master. Dubey sir, first of all, welcome. आपके बिना कोरम पूरा नहीं होता है. Thank you. So your question is valid. What kind of CT we should order? We should order fine sections, 0.5 mm axial sections, that's it. And we need to have a DICOM to reconstruct into all planes. So this CT was shot in axial plane only, both bone and soft tissue windows. So you can have complete anatomical details of the bone and soft tissue in the area you are going to operate. And now, with your DICOM, you can reconstruct into all planes. This data can be preserved for future reference. You can see dynamically which printouts cannot show you. With the number of slices in bone and soft tissue in axial, coronal, sagittal, to carry for a patient is impossible. And that too for a surgeon to see them on printouts, all those printouts is impossible. So the best is to order on DICOM because we cannot see dynamic otherwise and we can miss a lot of things. Like I had shown you all these anatomy This median now going to the foramen lacerum, this and that. This cannot be seen on, printout so easily. Secondly, there are certain anatomy which is visible best on axial. Certain details are given best on axial, certain on sagittal like frontal sinus and skull base, and mostly on coronal from sinus surgery point of view. So we need to have a complete 3D information. Secondly, this kind of CT scan gives you, our junior colleagues, a great opportunity to understand CT scan three-dimensionally. Any anatomy seen on axial, coronal or sagittal, you can correlate in all planes. Like for example, I told you, this is lateral recess. You can see lateral recess in all planes, where the lateral recess is going to be. See, this is, we saw yesterday greater palatine canal. See this? That's the greater palatine canal going to the palate. That's the greater palatine canal emerging from the pterygopalatine fossa medial part and going there. So all this anatomy you can very well appreciate. This is supraorbital cell. See this? See the cell above the orbit, supraorbital cell, and you can see this posterior anatomy to the frontal sinus. So every possible anatomy you can explore in all three planes. This cellar-sphenoid relationship is best seen on sagittal plane, the level of the cellar, the sphenoid sinus. The frontal sinus, most important view for the frontal sinus is the sagittal one, to give you picture in the right plane you need, and secondly, it gives you, to understand the opportunity how to access the frontal sinus in difficult situations. And you see, I will show you during surgery as well. See, when we come from this side, we are coming from this side, to address the frontal sinus, the biggest obstacle is this beak. Can you see? So the beak is a very, very important landmark. And you can use this as a landmark also to identify the frontal opening. See, I am coming from here, here, follow the beak, where the beak ends has to be frontal. It cannot be anything else. Yeah, so it is a fixed landmark. Even in the multiple revision surgeries, generally the beak is not disturbed. And you can utilize it as one of the best landmarks to enter into the frontal. So frontal is a bony cavity. See, all around bone is a frontal bone which is pneumatized and drained through the frontal recess. And this recess, see, this frontal sinus is bounded anteriorly by this frontal bone, floor by this frontal bone and the beak, and where the beak ends is the frontal sinus opening, drainage. So this drainage, if you come from anterior to posterior, this is the posterior most part. So frontal sinus drain from the posterior most region. See, I am coming, see in the coronal section, this is the frontal bone, beginning of the frontal sinus. This is the nasal bone, going behind, this is the beak. See, this was the nasal bone, this is beak. This is beak. Now, if I go further behind, where the beak ends, the frontal drainage starts. So frontal sinus drainage is from the posterior most part of the frontal sinus, then the anterior ethmoid roof starts. Now as we go behind, the cribriform plate starts that demarcates the anterior ethmoidal roof. And as we go behind, see still the cribriform plate. At the posterior most part of the cribriform plate, that is the beaking of the orbit. At the posterior most part of the cribriform, the anterior ethmoidal artery leaves the orbit. And where the anterior ethmoidal artery leaves the orbit and you go behind, then the posterior ethmoid starts. So, see this, the level of the anterior ethmoidal artery here. That's the level of the anterior ethmoidal artery. See in the sagittal plane, where the anterior ethmoidal artery level is. So, when we work for the frontal sinus from here, when we work for the frontal sinus in this direction, our anterior ethmoidal artery is miles away. You don't need to bother and frighten from the anterior ethmoidal artery from the beginning. the artery is far, far behind at the level of the skull base from the frontal sinus. So once you work with the frontal with a 70 degree, your artery is automatically far behind. Yes. So the advantage of the intact bulla is, see here in the sagittal, this is the bulla. This is the bulla going to the skull base. So as long as you stay anterior to the bulla, your artery is always protected. So once you remove the lamella of the bulla, then you will be able to see the artery in the skull base. I will show you during surgery as well. And this is the fixed anatomy which we need to exploit. Hello? Not really, sir. Volume बढ़ाओ. Yes, sir, now. Supraorbital cell and bular cell. Supraorbital, I have already shown you. Let me tell you. See, this is bulla ethmoidalis. The cell anterior and above the bulla is the suprabular cell. That is the suprabular cell. See here on the sagittal. Supraorbital, let me show you in all planes. First go in the, see this is frontal sinus. So beak is there means you are in the proper sinus so far. Now as we go behind, the beak has gone, it is the sinus drainage system now. There is no more frontal sinus now, it is the frontal drainage pathway now. And all this pneumatization above the orbit, can you see this? After the frontal sinus is over, we are far behind now. See in the sagittal, the frontal is over here. We are far behind, and this pneumatization going above the orbit is the supraorbital pneumatization. See this in all planes. So that is when the beak has gone. When the beak has gone and you have gone far behind. How you can additionally, have an idea about this? See, this is anteriorly the frontal sinus and the beak in place. And this is too anterior so that our maxillary sinus are not in view. Right. Now I am going behind. See, the beak has gone. Beak has gone, maxillary sinus have started appearing. Imagine the level on the coronal scan when you see the maxillary sinus. When maxillary sinuses are visible, you don't see the frontal sinus. Whatever you look like frontal sinus is actually a structure behind the frontal sinus, that is supraorbital pneumatization. So there are many ways to see that. And once you see the supraorbital pneumatization, go behind. See, this is the cribriform plate in place. That means anterethmoid is there. See supraorbital pneumatization. See this. Until the supraorbital pneumatization, see now. Now the supraorbital pneumatization ends and is the level of the anterethmoidal artery. See now, how far behind the anterethmoidal arteries. So whenever you see the supraorbital cell, the anterethmoidal artery is always behind, caudal to it. More the supraorbital cell is pneumatized. See, this anterethmoidal artery runs through the thickness of the anterior skull base. Anterethmoidal skull base is usually already thin. So most of the time this artery traversing through the thickness of the anterethmoidal skull base, it is visible as a prominent structure. Now if the anterethmoidal skull base is more pneumatized because of the supraorbital pneumatization or any other region, this artery becomes more prominent. So more the anterethmoidal skull base is pneumatized, more the supraorbital cell is pneumatized, you are more having chances of anterethmoidal artery into the mesentery, becoming more prominent. So all these structures are interrelated. So once you are working in the frontal, that's what I am going to show you. See this, I am going to show you the frontal sinus work immediately anteriorly. Will come with the 70 degree from here, follow the beak, where the beak ends will be in the frontal. While working this, imagine The anterethmoidal artery is miles away. You don't need to think of it. That is far, far behind, and that too right at the level of the skull base. See the level of the skull base? The anterethmoidal artery traverses through the skull base. So you don't need to frighten yourself unnecessarily all the time for the anterethmoidal artery. Okay, let me go behind. That's a very good question. See now, let me first tell you, this is cribriform plate. Now, I am going behind, the cribriform is over. See the posterior skull base, thick posterior skull base. Let me show you on here. Can you see the thick posterior skull base? See here earlier was the cribriform. When I am going behind, that is the thick posterior skull base. Clear? Now, as you go behind, see the orbit is narrowing. And this roof of the ethmoids is formed by frontal bone. That's how the top cells of the ethmoid are open from above, and that is roofed by the frontal bone and known as fovea. They give impression. Fovea means impression. They give impression on the frontal bone above. So, this ethmoidal roof, maybe whatever ethmoid, the ethmoidal roof is formed by frontal bone all the way. You see this frontal bone from pterion to pterion. Now, as you go behind, when the sphenoid sinus comes, sphenoid is what? Sphenoid sinus is what? Pneumatization of the sphenoid bone. And sphenoid bone is a complex bone having two wings, the lesser wing and the greater wing below. So, you saw the greater wing below yesterday forming the floor of the temporal lobe. I had shown in dissection. Now see, I am going behind. As long as this roof from pterion to pterion is formed by the frontal bone, it is posterior ethmoid. Whatever sinuses here are posterior ethmoids. The moment this roof of the frontal sinus goes off from pterion to pterion, the sphenoid starts. Let's see. See this? I am going behind. Behind. Can you see the roof is going? Now see where the roof is. There is no more roof laterally. This is the temporal lobe of the brain, and this is the middle cranial fossa. And see, this roof in the center is formed by the lesser wing of the sphenoid. So, whatever pneumatization below is the sphenoid sinus. Let me come back. See now, until now, see the complete bone from lateral to lateral. This is frontal bone and this is posterior ethmoid. As I go behind, now the frontal bone is disappeared. See the changes. See the broadening of the septum here, forming the rostrum. Rostrum is forming the anterior wall at the level of the anterior wall. See the orbital apex reducing. See the rostrum. That is the sphenoid sinus, beginning of the sphenoid sinus. Now, as you go behind, see the sphenoid sinus proper and the lesser wing of the sphenoid forming the roof. And as you go behind, see the sphenoid sinus, the orbital apex, that's the level of the pterygopalatine fossa on either side. Pterygopalatine fossa, inferior orbital fissure on either side. The sphenoid, body of the sphenoid pneumatizing into two sinuses. And as you go behind now see the pterygoid plates coming into place. On either side, the pterygoid process is coming into place. And now see the nasal septum is gone. It is not extending from top to bottom. Hello? Yes, boss.
How to identify the onodi cells?
Onodi. See, onodi is what? One of the posterior cell grows behind and above the sphenoid sinus. Grows behind and above the sphenoid sinus and beyond the anterior wall of the sphenoid behind. Yes, boss. Hello? Yes, yes. So your question was regarding the onodi cell. See, I am going behind to the posthethmoid and show you the sagittal part. Onodi can be viewed in any plane. See, this is sphenoid sinus. This is anterior wall of the sphenoid sinus. Now, any posthethmoidal cell growing beyond the anterior wall of the sphenoid sinus is onodi cell. And how it will appear in the coronal sections? See, this is posthethmoid. This is sphenoid, pure sphenoid. Had there been any onodi cell entering into the sphenoid, this sphenoid would have a transport septa, the upper cell being the onodi, the lower cell, the sphenoid being pushed infero-medially. So if you see in the horizontal septa in the sphenoid, that means the upper cell is continuation of the posthethmoid, which has pushed the sphenoid infero-medially, and in that situation, the optic nerve comes to lie in the wall of the onodi rather than the sphenoid sinus. Is that clear? This particular patient has a, as far as the positive, anatomical findings are concerned, has a reasonable size frontal sinuses, not very big. Frontal recesses, hardly any pneumatization. Has complete white out, picture of the sinusitis. Complete white out, bilateral pen sinusitis with a lateral recess of the sphenoid on the left side. See this? That's a lateral recess which is at the expense of pneumatization of the pterygoid process. In the CT scan, rules out any other diagnosis, any mucocele, any other abnormality. As far as the diagnosis is concerned, it hardly has any role.
Sir, sometimes this lateral recess pterygoid pneumatization can also be diseased. So you will approach it through the sphenoid sinus.
Yes. See this, madam. See where the lateral recess is. This is lateral recess. Yes.
These days you are getting MRI for paranasal sinuses surgeries.
Yeah.
Can you tell us the advantages why instead of CT you are getting MRI?
See, MRI has its indications. For inflammatory disease of the paranasal sinuses, generally you don't need MRI unless you have a doubt on diagnosis, unless you have a doubt on having some sort of tumor, unless you want to confirm about the fungal disease, or you want to rule out anything else, or the disease is extending beyond the confines of paranasal sinuses, intracranially, intraorbitally, anywhere beyond the confines of paranasal. Unless then the CT is good enough, otherwise the MRI is indicated. So MRI has its indication. MRI has versatility of giving number of different sequences. Every sequence has a value and identifies certain particular thing. You can easily differentiate between soft tissue masses. See, here you can see only opacity on CT scan. Whether it is a fluid, whether it is a fungus, whether it is a mucosa, whatever it is, you cannot differentiate. MRI can exactly differentiate if it is a fluid. If it is a mucus fluid or it is a pyocele, MRI can differentiate by means of differing protein content. If it is a fungus, MRI can differentiate whether it is a fungus or not. Whether it's a regular sinusitis or a fungal sinusitis, MRI can differentiate. So MRI has a value in terms of differentiating into soft tissue masses. For a pure inflammatory disease of the paranasal sinuses, generally you don't need, MRI unless I have told you the indications.
Sir,
Yes, sir.
is there any role of navigation system in sinus surgery because a lot of big institutions are buying navigation system.
Yes. See, navigation systems have the value in improving anatomical localization. What do any navigation system generally do? They, the CT scan is registered with a navigation system and the patient head, and wherever you point out a navigated instrument, that will exactly tell you on CT scan where exactly you are working. And now, yeah, so it improves your localization. And now with the more sophisticated navigation systems have come in, the accuracy is within 1 millimeter. So it is more important when you are working close to critical structures. So in the present scenario, if you are experienced for a regular sinus surgery, generally you don't need navigation. It is not, something about the anatomical details of the surgeon, but it helps in orienting in difficult situations, like in unusual anatomy, unusual cellularity, and in a revision situation when the anatomy is distorted, in tumors or disease close to the critical structures like carotid artery, optic nerve, dura, orbit, and you really want to know where exactly you are working to improve your localization and avoiding complications. If you have a tumor or something you are removing close to the carotid artery and you want to know exactly how far you are from the carotid to protect that, you can use the navigation system. So navigation system has a role in improving your localization in difficult situation, not in every case. Yes, in revision and more extensive cases where the disease has gone beyond the confines, navigation definitely has a value.
So you have a navigation system at your place. How often you use this navigation system?
Me, once in 3 months
Once in 3 months.
on an average. I've been using for almost now 15 years. These are straightforward cases, you don't need navigation. You see, it depends upon the surgical experience as well.
Right.
But I am not against it, and this is a good teaching tool in the institutions.
Right.
See, if your resident is working, using the navigation system, you can monitor
Yes.
all the time where exactly is working. You can ask him to point out where exactly you are working and you can see on monitor.
Right.
So it adds on to the safety when you are, teaching.
Right. Thank you, sir.
So we're discussing the grading of this sinus. So we'll do by sphenoid sinus only.
Pardon?
So the sphenoid versus grading we'll do by exposing the sphenoid sinus only.
Yes. So this is basically, a inflammatory disease of the sphenoid sinus. What we need to do in this entire surgery is to remove this inflammatory load and establish the ventilation and drainage and wide opening for future, introduction of topical steroids. This is not a tumor, this is not a CSF leak, this is not something else. So in this case, you don't need to reach out that area. You just, through the natural ostium, you widen the sphenoid wall, suck out the disease, or if it is a polyp, you can debride, whatever, and establish a good patency for future steroids to go inside. Had this been a CSF leak, which is not uncommon from the lateral recess of the sphenoid sinus, in that scenario, you need a head-on approach. And what you can do, we had seen yesterday, this is the medial pterygoid plate, that's the sphenoid wall. You can remove this sphenoid wall and part of the pterygoid plate and open head-on. Once you open head-on the lateral recess, you can close the CSF leak like a child's play. See, in CSF leak, wherever you are dealing with, the important thing is the exposure. If you get the exposure, the method of sealing is same. So in lateral recess leaks, you need a transpterygoid approach to deal with the lateral area. So our case is induced probably, and in a couple of minutes we are going to start. You can continue your questions during surgery also. Feel free to interrupt me anytime.
Hello. Yes.
Hello. 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 Yes, sir. Yes. Can you raise your volume, please? Hello. Yes. Yeah, yeah, yeah. You're audible now. Please. Mm. Okay. Okay. How to go by the transpterygoid approach? Yes. Opposite side? Yeah. Not really. Hydrogen peroxide is something not to melt the fungus. You can use the hydrodebrider, which is a jet. You can rotate 360 degree and you can flush it out. By and large, for sinus surgery, we must have a high power suction, like a liposuction, to enhance your visualization, to prevent the repeated clogging of the suction, at the same time to improve the durability of the microdebrider motor.
यस सर। विनय डॉक्टर सतीश को माइक लगाओ।
Pre-operative preparation is of immense value along with the intraoperative preparation.
So you give steroids in the tapering dose or the same dose continuously?
Tapering dose. We use plain prednisolone, starting 1 milligram per kg, then tapering after 3 days to half a milligram, then tapering further like this until the patient is posted. Sometimes, I told you why it is not practical sometimes for patients coming from long distances. Plan for surgery you can't keep for waiting, waiting for long, and you have to, emphasize on other ways of reducing the inflammation and bleeding rather than keeping the patient waiting for long. So many times that is not practical, but by and large, your intraoperative preparation, a thorough intraoperative preparation gives you, good surgical field. Yes, matters a lot. See, this inflammatory disease of the paranasal sinuses, we have understood a lot about it, and now there are lots of, phenotypes and endotypes of this disease. Each endotype having a different ongoing pathophysiological process. Like non-polypoidal disease is a different phenotype, different endotype, which is mostly eosinophil dominated disease, and steroids have hardly any value, and in those the antibiotics have more value, and antibiotics particularly targeting the neutrophils, working as immunomodulators, the macrolides have huge value. In all non-polypoidal sinusitis, we must give a course of macrolides at least for 3 to 4 months in low doses to modulate the immunity, to modulate the course of disease, and many times we can, avoid the need of surgery. But yes, in polypoidal disease, there is no value of, macrolides. That's a eosinophil dominated disease. And in that eosinophilic dominated disease, in the entire cascade of pathophysiology, the only thing which works is the steroid. So this is my 5 to 10 minutes of topical preparation. And now moving on to the surgical part. And you see there are a lot of polyps occupying the nasal cavity. So the first is the luminal work. This is the Medtronic blade.
How about keeping the packs for 10 minutes of these decongestant?
It's not.
Will that help endoscopically put packs?
Yeah, which I have done.
Yeah.
See, this packing, there is a way of packing the nasal cavity for the optimum field. It's not that you pack it tightly. If you pack tightly, it is more counterproductive in terms of giving venous congestion. So we are not supposed to pack tightly, number one. Secondly, we are not supposed to pack for longer duration. Whatever, our aim is to apply adrenaline, that's it, to the surface. If you keep the pack for 30 seconds and keep for 5 minutes, the effect is going to be same. So there is no point in keeping the pack for longer period. Depends. In younger patients, we don't mind using even a pure 1:1000 because we are using only for topical use. In elderly, yes, particularly in cardiovascular labile patients, you have to dilute the concentration to prevent systemic dissemination and systemic side effects. And mostly in those patients, we use 1:4 combination for topical use. No infiltration at all in any case. See, multiple polyps have, distorted the anatomy. Now, can you see something coming in the picture? That is middle turbinate. And see the important thing, lot of disease medial to the middle turbinate. You have to be very careful. See this. Above is the olfactory mucosa. Be conservative in removal of these polyps by means of not damaging the mucosa. Yes, because whatever these polyps, even if you stay conservative and push your topical steroid later on, which is the goal of our surgery, these can be tackled very effectively without unnecessarily, damaging the olfactory mucosa and giving olfactory loss. So you have to be little conservative in the olfactory region. See, leave that, remove whatever surface you can debride and avoid fibrosis. If you give fibrosis, you'll end up giving probably a permanent olfactory loss. Because most of the time, this olfactory loss is conductive. What I mean to say, this olfactory loss is of two types by and large, conductive and sensory neural. Conductive means your polyps blocking the air reaching the olfactory receptors. That is conductive olfactory loss. The moment you remove the polyps or allowing the air to access the olfactory region, then your olfaction reverts back to normal. Majority of the time it happens like that. But if you give lot of fibrosis by means of debriding in that region, you end up damaging the olfactory mucosa, and that can be a permanent olfaction loss. Pardon? Yeah, so this was the luminal component I was doing. So I was using the straight blade and keeping the blade in view so as to avoid the trauma to the surrounding. And see, I have given a small trauma on the middle, on the surrounding surface, on the turbinate here, on the septum, little bit. So I will coagulate it immediately. So always whenever you use debrider or coagulator, whatever, keep the blade, tip of the blade in view all the time.
What is the blood pressure, Dr. Satish?
Blood pressure is around 128/93.
And pulse rate?
Pulse rate just now it has increased, but it was around 60-65. It is in 80s now, but probably it will settle down.
For you, pulse rate is important or blood pressure?
Yeah, more is the pulse rate. But blood pressure is important in the sense, it's not that you are going to operate in hypertensive conditions. Obviously, then the overall bleeding will be more.
On the surgical field, you are concerned with pulse rate between 70 to 80.
Around 60. Now see, there is one thing which we always mention. In case of disease medial to the middle turbinate, it results in lot of issues. Lot of issues means, number one, it results in a floppy turbinate once you have a lot of disease medial to the middle turbinate. It makes your turbinate medialize and ultimately it becomes floppy. And a floppy turbinate needs to be managed by various ways. In the morning I was discussing with Madam Srivastav. A floppy turbinate can be managed by various ways. Most of the time, either you do a Bolgerization or you do a suturing at the inferior edge. At the inferior edge to keep the middle meatus open like this. But see, our policy, when you have a massive disease in the olfactory region, we don't do, or rather we do a partial resection to allow the solution to reach freely to the olfactory region. So there we do intentional, partial resection to give free access to the topicals reaching the olfactory region. Got my point? Yes, so in cases where there is a floppy turbinate with a disease medial to the middle turbinate in the olfactory recess, olfactory region, it is better to do a partial resection. Partial resection means a partial resection, not complete chopping of the turbinate. Because this turbinate is a useful landmark throughout the surgery.
So you will remove the lower third of the middle turbinate.
Lower third is even more, but not the superior part, which has a, which can have a probable, olfactory mucosa also medially. And secondly, it acts as a good landmark as well. See this floppy turbinate, it is falling laterally. Can you see? So if you don't do anything to it, what can happen? This is going to block the olfactory cavity and defeat the entire purpose of this surgery. Because our purpose of this surgery now is many pronged. In the sense, it is not that, we all know, this is a steroid dependent disease. The entire, the steroid works at the entire cascade of the pathophysiology of this disease. So the only weapon we have in the present context to deal with this disease is steroid. Now we can't give oral steroid. Topical steroid, looking at the profile of the disease, looking at the number of polyps, the sinuses blocked, the topicals are not penetrating unless you open up the sinuses. Got my point? So, the sinus surgery, number one role of the sinus surgery is to remove the inflammatory load. Number one. Number two, to open up the ventilation and drainage, to establish the ventilation and drainage of the sinuses for their health. And number three, to give avenue for the topical to reach in the depth of the sinuses. So that is the third goal, and that is one of the most important goals now. So that since we have only weapon in the present context to deal with this disease, the steroid. In that situation, when the topicals reach freely into the depth of the sinuses where the disease is, where the mucosa is diseased, you don't need to give oral, and these topicals are pretty safe with hardly any systemic side effects in long run. So that is the whole goal of surgery in the entire context. Can you see the picture? How is the picture overall?
Yeah, very good.
So, yes, hello?
It's very good, sir. It is very good.
Yes, sir. Yes, please. Wash. Yes, macrolides are not fuel because their main work is on the neutrophilic receptors. Yes. So doxycycline is used for polypoidal disease not as an antibiotic. See, in polypoidal disease, cascade of sinusitis, eosinophilic, there are a lot of receptors where the doxycycline works, particularly the matrix metalloproteinase 9, which is an important part in the cascade of polypoidal sinusitis. And this doxycycline is used as an immunomodulator to block the matrix metalloproteinase to give, inviting the eosinophil to the area. So doxycycline is never used as an antibiotic, immunomodulator. Similarly, macrolides are never used like antibiotic, they are used as immunomodulators. So generally it is given for 3 weeks. See, if your inflammatory load is not so much and can be contained with doxycycline, saline wash and topical steroids, all are pretty safe. You don't need surgery. But if your load is too much, not getting control with all these conservative measures, then you have to reduce the inflammatory load by means of surgery. See this? Before going anywhere, now I am taking this, part of the floppy turbinate to give me good access to the olfactory and overall middle meatus.
So you use only prednisolone, don't with newer steroid like depressiport or methylprednisolone?
For?
You use only prednisolone, not using depressiport, these modern steroids?
Yeah, for the oral use.
Oral use, yes.
Yeah, mostly prednisolone. See, all steroids have their own potency. They have relative potency. Like methylprednisolone is relatively more potent than prednisolone, and deflazacort is relatively less potent in terms of dosing. So accordingly, you need to escalate the dose, and you can use. So all are steroids, all have same glucocorticoid activity. So by and large, they are all are same. You have to adjust the doses according to the, potency.
Oh.
Yes? Reconstruct what? Yes, so reconstruct. Yes, so that the penetration to the frontal is improved. I will show you. That is the concept of known as 0-degree visualization of the frontal sinus. I will show that. That is good. We appreciate that. See now, I have partially resected the middle turbinate to open up the olfactory region. See that? Had there not been any polyps medial to the middle turbinate, I would never resect it. I would rather bulgarize inferiorly or suture it. Once there are polyps, not to take chance, because now I want post-operatively my steroid to reach freely to the olfactory region. See that? See, every time keep improving your field. To minimize the complication, since this is a surgery of landmarks, every point of time you need to identify your further landmarks.
Sir, what about this high DNS which is obscuring?
Yes, if it is really obscuring, you must correct it. If you want to know how to correct, like yesterday I had shown you, I can show you today as well, with a conservative limited septoplasty. Okay, you want me to show that?
Yes, sir.
And it is always a good approach. You know what happens? Intraoperatively, after decongestion, you feel like you have adequate space. And you can negotiate your instrument through whatever space you have created after decongestion. But instrumentation through the narrow spaces invites injury to the opposing surfaces and ultimately may invite synechia. So on the slightest doubt of, high deviation, narrow space, you can always, improve. You can either see this high deviation I can reduce in a minute. See this?
Yes.
If you want me, okay.
But I think your
Knife.
use is also causing very
Knife,
less
knife.
trauma to the mucosa.
Yes. So it gives me a good decongested feel. So I can tell you, I can show you this high deviation since you have asked how it can be easily improved. See this? My incision to the opposite side. I have not infiltrated anything for that matter.
Yes. So why it is not bleeding in your hand? Satish bhai,
It's not my hand. We have to follow the protocols.
everybody is asking this only. That is bleeds in our hand. Why it is not bleeding in your hand? It's a erosive pocha which has done all the
Yeah. So Marocell has a role, or anesthesiologist has the credit to give me this good field. See, this was a case where the septoplasty was done earlier.
Right.
I can see you have to be more careful now, because you can't expect that good surgical planes. Yes, but see this, I got the plane.
Yes.
And see, this is the high deviation. See, such things when it comes to your mind to correct, you must correct. See this high deviation?
Yes.
I will correct it and that's it. It doesn't take time, hardly any bleeding, no side effects. You must do it to improvise. It helps you achieving your goal by means of introducing the post-operatively the topical steroid in the cavity. See this?
Yes, sir.
That's it. Yesterday I had shown you a limited septoplasty in a different way. Today also in a different way. See now?
Yes.
No more high deviation now. See this? Hello?
Yes, sir.
Yes.
So you can, terminate septal deviation. All these are ancillary procedures required in almost every sinus surgery.
Ultimate goal is to reach the penetration of the
Topical wash. So you have to do everything. You have to make sure that the topicals reaching effectively. See now, with this high division correction, now see the field.
Yes.
Dramatic improvement. The goal is you can see your patient in your office in the post-operatively with a 0 degree, with all sinuses, and you can train your patient, for the topical steroid wash, and now it will penetrate like anything. See that?
Very good.
So all these inferior turbinate, middle turbinate, septum, and other things required to be corrected, we must go for that. So now coming to the sinus surgery per se. Now see, yesterday in the cadaver we had seen a lot of landmarks, the inferior turbinate, inferior meatus. In sinus disease, the most important area we are concerned with is the middle meatus. See, it is all distorted. Can you see?
Yes.
It is all distorted because of the polyps itself. See, it's because of the polyp itself. Mobility. I always mention.
This is the only structure
which is mobile in the lateral nasal wall. See this, the polyp?
Yes.
And see this opening, what is this? This cannot be natural ostium. This is a fontanelle. This is the fontanelle. This cannot be natural ostium. See, this is behind the uncinate. So it is a posterior fontanelle. See this uncinate?
Yes.
Always communicate this fontanelle with the natural ostium. Reason being, your secretions, your sinuses drain through the natural ostium. If you don't communicate with the fontanelle, whatever secretion come out of the sinus can re-enter through the fontanelle, back into the sinus. And our entire purpose is defeated again. So always give a wide opening and communicate these three things together. Dubey sir, your questions are very relevant, most important for the benefit of everybody. Please.
Sir, I am also getting benefited by every tips which you shown, and
What is it?
this section was excellent.
काउट देना आपकी प्रेजेंस ने 4 चांद लगा दिए काउट सेक्शन काउट
Sometimes this inferior turbinate is very high.
Yes, be careful to avoid an orbital entry in that situation. Go just above. See the maxillary sinus mucosa? This is a sort of, you can say, cobblestone appearance mucosa. Don't be aggressive on such mucosa. Never be aggressive. See the goal of this surgery, this is functional endoscopic sinus surgery, wherein the entire function is going to be solved by mucosa. If you remove the mucosa, you are defeating the purpose of sinus surgery. Then you are going to invite the fibrosis. That is not going to serve the mucociliary clearance, and the entire purpose is defeated. And then it is not going to be fast, it is going to be total mess. So never ever, Yeah, see, these spicules of bone, always use a sharp instrument. Separate the mucosa and pick them, remove. See why cobblatory here, this debrider is so important. Because this is a sharp cutting instrument. It cuts the mucosa sharp. It doesn't pull anything. It doesn't demucosalize the area. See my maxillary sinus? A simple middle meatal antrostomy. I don't intend to enlarge it much because I don't see any massive disease inside. There are grades of maxillary antrostomies in case required. In case required means, had there been a massive disease, fungal or anything requiring a lifelong or long-term surveillance, I would have, created a bigger opening, a mega middle meatal antrostomy for the future steroid introduction, future surveillance and all that. This maxillary sinus not having, you can see, not having a massive disease, you don't need to be very, very aggressive in doing anything over there. Yeah, this mucosa has to be respected. Now, this is your bulla. See this? And this is your upper part of the uncinate. Can you see? No, no. That is non-invasive fungus. AFRS is non-invasive fungus. You are not supposed to remove the mucosa. AFRS is allergic fungal rhinosinusitis. That is the patient's reaction to the fungal antigen. That is pure type 1 hypersensitivity antigen antibody reaction. So the mucosa is secreting eosinophilic material in response to the fungal challenge. The mucosa is not invaded by the fungus. Never ever try to remove the mucosa. So it's not behind. You know what happens sometimes? In between the mucosal polyps, you can leave the fungal antigen behind. It's not behind the mucosa or invading the mucosa. So in that situation, you need to have a thorough wash to ensure that no fungus is left behind. If fungus is left behind, it will behave like an antigen wash. In AFRS, the fungus is antigen. Don't leave the fungus behind. See the value of irrigation, mopping, all that to maintain your surgical field. Not really, sir. Invasive fungal sinusitis, on the other hand, is a medical disease. The role of surgery is just limited to confirm it by means of taking a biopsy. Suppose this patient is having invasive aspergillosis.
Yes.
I could have known by CT scan also all those distraction, bone distraction. And that kind of bone distraction is different than bone distraction you see in the allergic fungal rhinosinusitis. Then, because the sinuses are not full, even the small disease in the sinus can lead to bone distraction. And then in that invasive disease, you just take a biopsy and come out. Once it is proven invasive aspergillosis, your voriconazole is the treatment of choice. You don't need to do at all any extensive surgery.
Okay. But in like in mucormycosis,
That is acute fulminant. Mucor is acute fulminant disease. Again, that is medical disease. Mucor is again medical disease wherein amphotericin is the treatment of choice. The difference is,
remove all the dead bones.
it gives vascular necrosis. Mucor preferentially invades the vessel and gives vascular necrosis. Now, the areas which have developed vascular necrosis, your antifungals are not going to penetrate. So the goal of surgery is MRI based, the contrast MRI. Wherever the contrast is not going, wherever are the dead areas, you have to remove them. The antifungals are not going to reach there. And wherever the contrast is going, in spite of being fungus over there, you can leave for the amphotericin. Except the bones. If you have a disease in the bones and enhancing on contrast, you need to remove because the penetration of amphotericin in the bone is very poor.
And there is no role of any antifungal topical.
No, zero. Just a feel good, nothing else.
And what about that ointment which was very much
That's a feel good. See now, this is the upper part of the uncinate I am taking off. This is a very, very important step in sinus surgery for all junior colleagues. Moment you remove the upper part of the uncinate, you reach out to your lateral limit of the sinonasal corridor. That is what? Lamina papyracea. So in a minute's time, see this. We have reached the lamina papyracea. See this? This is lamina. That is my lateral limit of the sinonasal corridor. That too in so beginning of the surgery. My medial limit is turbinate, which we have defined. My lateral limit is this. See this? My bulla is intact. The maxillary sinus is here. This is axilla over there. Now how to reach out the frontal? Having seen this?
yes, to the beak.
Beak is the landmark, boss. See this. For anybody practicing sinus surgery, intend to do sinus surgery, A beak is one of the best landmarks. See this? This is what Dr. Kumar Raja was asking, to clean the beak region thoroughly. See this? I am working far anteriorly. And how can you identify the beak so easily? Beak is the thickest bone in this region. With knowing my lateral and medial limits. See this, what I am doing. Knowing my lateral and medial limits, the lateral limit being the lamina there, medial limit being the turbinate, staying on the beak. See this? You can identify, see this is axilla, and see, follow this axilla with the beak behind. That is the beak. That is thick beak. And where the beak ends, that is the frontal sinus. See that?
Right.
So easily you can reach out the frontal sinus. Now let me elaborate this. This is the simplest way of reaching out the frontal rather than wandering here and there, rather than terrifying yourself with the frontal being a challenging sinus. You can reach out there easily with a single landmark, and that landmark is so reliable, it is not destroyed even in the multiple revisions, because nobody is going to drill away the beak.
Would you like to raise a flag on the lateral side of that accurate argument?
Yeah. Yes, a lot of people do that, but see, if it is followed by the good irrigation, you don't need to do that. Now, at this point, what I am trying to show is what Dr. Kumar Raja has asked, and this is our, proposition also. See this projected bone at the level of the axilla. I can remove only the projected bone, and now I will go inside with the 70 degree to show you something, and you are directly onto the frontal sinus. Your all terrifying things, the anterethmoidal artery, skull base, all those things are miles away. They are behind, they are miles away from this most anterior anatomy which I am working at. Look, give me 70. So now switching to the 70 degree for regions.
How it is different from the auxiliary flap technique which was popularized by the Warhol?
Yes. Yes. So that was initially, popularized by Wormwold for the regions not using the 70 degree. That time, people were not using 70 degree, not confident of that. So that is something to get away from using the, I would say, the appropriate technique. Yes. See this. And you can
also we can see the frontal in future and irrigate with 0 degree only.
See this 70 degree. The beauty of 70 degree is you can keep your all landmarks in visualization at one point of time. Means I have my medial limit in view. Why terminate as a medial limit? If I transgress this medial limit and go medial to it, I can easily destroy the cribriform plate and a CSF leak. See the cribriform plate there. So I need to keep my medial limit. This is my lateral limit, the lamina. If I transgress, I will be right into the orbit immediately. And if I stay in between these two, follow my beak. See, this is the beak. Follow my beak, I will be right into the sinus. That is frontal sinus. See now? So simple. Going in between these lateral and medial limits, far anteriorly, I am entering into where? It cannot be anything else. That is your frontal sinus. So the best way to reach out the frontal sinus safely is the beak. If sometimes you find a projection in the beak, you need to remove that. Articulated.
That we remove with your spinal grid or with calcium muscle?
Yeah, I have a special articulated punch for that. We'll show you. First of all, look at the frontal sinus. See, I'm working far anteriorly. That's what I'm again and again emphasizing. Once you are working far anteriorly, you are away, miles away from all the critical structures you can think of damaging. Nothing critical structure coming in, going to come your way. See this?
Yes, very clear.
What is that? Frontal. So the moment you see your medial and lateral limit, go in between, go anteriorly, just below the beak, it has to be frontal, nothing else. You don't have to apply your brain or anything into it. It is always has to be frontal.
And where is your special concept?
Yeah. Now see, that is the frontal sinus.
Wide.
Now, if you want to further widen this with this, beak or something, what a frontal it is. See this frontal. In no time, I didn't take into consideration any other landmark. Now, this beak projection I can cut away. See this?
Yes, yes, yes.
This, अरे सिर पकड़ना यार. This is my
Special punch.
special punch from Karl Storch. And see, you know what it is going to help us? This will help the topicals reaching more efficiently into the frontal.
All these point water mucosa, which are
Yeah, no, you don't have to do anything aggressive to the mucosa. Once the steroid start reaching there, it is going to go. See that? So frontal, believe me, follow the beak, no challenge.
So whether you wash this with steroid solution right now or it will be for post-operative period also.
Post-operative. Post-operative. See the frontal sinus. If you want to remove further this beak, to improve the topical penetration, see that is the concept of 0-degree visualization. Remove this beak middle turbinate complex anteriorly to give a 0-degree visualization to the frontal. See this? Yeah, very, very strong punch it is. Yes, I will. Yes, I will, sir. This is amazing tool from Karl Storch. Yeah, the right. Widest for this particular anatomy. Further, I will further widen it to the maximum. And then I will show you the picture with a 0-degree.
Sir, people want to see the punch.
Yes, give me. So this is a articulated punch.
It is almost.
Yeah, yes, this is Karl Storch. And it has multiple articulations to give it an angulation. And this is a very, very solid punch. You can, which over 2 lakhs.
2 legs, over 2 legs.
But amazing thing.
Actually, saying that Kalkar is also having the same.
No, but I've used that. Cannot beat Storch. The angulation is different, with the punch. The angulation punch.
And how long you are using it, sir?
Naresh.
It's a very durable instrument.
Yeah, I've been using this for almost more than 8 years now.
Oh, so it's a birth.
Yeah, Karl Storch equipments that way are, I would say, cost effective also. I know they are costly, but worth and cost effective in the long run. See this? Widest frontal sinus exposure you can think of?
Sir, in the last conference, you rounded off the lower edge of the axilla with a small drill.
Yes.
Hello. Can you just show us this?
Lower end of the? I didn't get your question.
Last time when you operated, you rounded off the lower edge of the axilla, that bare bone, there.
Yeah, with the drill.
Yes.
Just for the sake of demo. That's it. You can in case needed. See what I'm using. The so-called adenoid blade, which I condemn to be used for adenoids. We have written to the company to be banned for adenoid surgery as a rear-facing blade. Lateral lamella? Yes. Like I showed you yesterday in the cadaver. Remember? Let me tell you. I will tell you once I come to the anterethmoidal artery for sure. See the area where I am working. Caudal to the frontal. Frontal sinus is anteriorly. And what is this recess which is going up and laterally? See this? This is supraorbital recess. This is caudal to the frontal sinus. See this? And see, my bulla is still intact. Still, I didn't utter a single word about the concern for the anterethmoidal artery because I need not to worry about that. That is far posterior. I had shown you on CT scan also. Don't need to start,
Now, what is the care in secondary cases?
What is the
Care.
care?
During the surgery.
Revision cases. Revision cases, the only landmark challenge is the identification of landmark. Always. Any revision surgery in the body. Landmarks, because your original landmarks are distorted then because by the previous surgeon. So you have to be more, experienced in identifying the landmarks. See my frontal and see the limits. See the limits. See my turbinate which I left here for identification. Can you see? In spite of partial resection of the turbinate, I left there a part of the turbinate.
And how do you identify the frontal supraorbital?
Supraorbital cell is always caudal to the frontal sinus. See, the frontal is above, and next thing going laterally the supraorbital. So that is always lateral to it, lateral and posterior to it. Now coming to the bulla. See my turbinate in place, middle turbinate. What I am keeping with 70 degree in view all the time? My medial and lateral limit. This is my medial limit, this is my lateral limit. Anything you want to do, you can play around in between these two. And we took the third reference of the beak to enter into the frontal. See, so simple. This was the axilla, remember? This is the beak, and where the beak ends, what is there? Frontal. When God has given such a straightforward anatomy, why not to exploit it and looking for here and there so many things for the frontal unnecessarily? Now see, this is your the bulla. Can you see? Hello? This is your bulla. I am getting this bulla fractured. Go behind and fracture it. See this? Go behind and fracture it, get rid of this bulla. See this? Reverse that one. Chalo. Now it is garbage. This goes up to the front, to the skull base. I told you, my anterethmoidal artery will be immediately caudal to the supraorbital recess. Oh. For you, You can see the artery. Can you see the vessel? Now suppose, yeah, yes sir. ठीक है, ठीक है, ठीक है. Perforation, ना? Suction, suction. See, if you get slight puncture into the vessel, hello? Yes, sir. Don't need to terrify yourself. Give me a mirror cell. This is a sub-millimetric vessel, you know. The diameter of the vessel is less than a millimeter. Just apply your surgicel, this marrow cell for a minute and it will stop. Don't need to worry about.
Still using 70 or 0?
70, 70. 70 is always a good telescope to, it's more versatile telescope. You can go anywhere. I can rotate my cable and see the maxilla there behind. I can rotate the cable and see anywhere, all around. One of the sinuses? Yes. Yeah, depending upon the disease. If this is an eosinophilic disease, and if you are doing a rest of the sinuses on one side, why not to open it to allow the steroid to reach inside? That's it. It will not harm anything. See my skull base there? That is caudal to the patla. Caudal to the supraorbital cell. Yes, now we'll be free in a minute's time. And now we'll look for the anterethmoidal skull base. Complete anterethmoidal skull base with our skull base burr. Skull base burr is what? Adenoid burr. Wash. Yes. Bipolar, always bipolar. A section bipolar. For a small rent or anything, you don't need anything practically. Yes, if it is a complete transaction, then it is advisable to use a bipolar. Give me reverse blade. Reverse blade. See this? See the entire frontal sinus and the ethmoidal skull base flushed.
Yes.
You are not leaving any cell uncovered so that your solution doesn't reach in future. बंद है यार ये. Close. पतला दे, छोटा दे, इसका भी छोटा. The suction is closed. छोटा. So always use the adenoid blade for the skull base work. Clogged, blade is clogged. Open up. Don't leave any cell uncovered. If you leave any cell uncovered, your topical is not going to reach there and it can lead out to the mucosal disease again, maybe polyp or anything else. No. There. See now my skull base blade. अंडर विजन ब्लॉक है यार ये. Why don't you see? ब्लॉक है गुरु, ब्लॉक. The blade is not working. And this is how you can flush your entire ethmoidal skull base. See that?
Yes.
Oh, there.
You do very good surgery, tell your patient to wash it regularly, but sometimes he forgets to wash and subsequently he comes again to you after 3 months.
Yeah. So,
Polypoid disease, then what to tell him how to contact him, because he's always doing and coming and blaming you.
that's why. That's why the counseling, pre-op counseling is so important. ये चल नहीं रही यार, देना कुछ 10 बार कह दिए थे. See, pre-op counseling is so important. You are not supposed to tell your patient that we'll operate on your sinuses and you'll be all right.
Right.
That is the biggest joke you can crack for this disease. You have to tell your patient that this is a steroid dependent disease. You have two options now. Either to take the steroids forever. You take the course of steroid, it will improve. The moment you stop, it will come back with the same problem. So the best is to open up the sinuses, remove this disease, and give the topical steroid to go inside, so you don't need to take oral steroids. That you need to counsel. The patient should understand why he was operated.
And how often he should come to you?
Depending upon the profile. That's why the lot of the series of investigations are required to ascertain the particular endotype of the disease, what kind of disease it is, how much eosinophilia it has. Say this. Yes, always a part of the. See, there is no bleeding. Hello? That's the mucosal ooze, nothing else. And see the entire anterethmoidal skull base completely flushed. So you have to counsel your patient that we will train you post-operatively how to push the topical steroids. In the present context, there is no other weapon with us to treat your disease than steroids.
Apart from washing it regularly, do you recommend some other, immunotherapy or any
Yes.
recent medication?
Yes. Yes. That's why I always share the list of investigations, number one, and the comorbidities which can be associated with these patients. Mostly, it is the localized suppressed immunity which has resulted into this disease. So, anything which improves the immunity is going to improve the situation, Like, for example, probiotics, prebiotics to improve the gut flora and nasal microflora, to improve the richness and diversity of the good bacteria is going to improve the situation. So we always add these patients for long term the pre and probiotics, number one. That is something which helps. If patient has associated allergic rhinitis, then you get the allergic testing, skin prick testing and immunization. Antihistamines have no role just to control the symptom as long as they take. Antihistaminics do not change the natural course of disease. Can you see the vessel?
Yes.
See the vessel? That is the suprabular cell you were asking. Just anterior to it.
Yes.
And then it is the supraorbital cell. Can you see very clear?
Very clear.
And above is the frontal sinus, and this is 0-degree visualization of the frontal. See that? Because we remove this beak middle turbinate complex. Can you see?
Yes.
Removal of these beak middle turbinate complexes allow the topical to reach more efficiently into the frontal. So simple. No bleeding?
So any role of vitamin D
Yes, second is vitamin D. Yes, those having extreme deficiency of vitamin D. See, marginal deficiency is very common. That doesn't affect, but extremely vitamin D deficient people should be replenished and it improves. Those who are smokers should be encouraged to curtail the smoking to improve the mucociliary activity. And acetylcysteine is nowadays more and more used as an antioxidant rather than, mucolytic. Mucolytics have no role. See now, we have done anti-rheumaticectomy, we have done frontal, we have done maxillary. Can you see all clear? Now in order to enter the posterior, this is ground lamella. This is the maxillary sinus roof, the orbital floor. At this level medially, one can enter into the roof, into the ground lamella. Why at this level? This is maxillary line. Why at this level? If you try to go above this, you can enter into the skull base so easily. See this? Yes. So never ever. Stay below in the level of the maxillary line. Bandai. The moment you enter into the posterior, now we have two things left on this side. Posterior and sphenoidectomy. I will not do posterior first, I will do sphenoidectomy first. The reason being, posterior is followed behind by the sphenoid. And we never know when the sphenoid starts. If you are lost, you can damage the critical structures in the walls of the sphenoid like carotid and optic. So we should know where the sphenoid starts. If you know where the sphenoid starts, you can accomplish your posterior sphenoidectomy under vision without any problem. So what I will do here, at this level, go medially. Since we have already removed the part of the middle turbinate, so our life is much easier. Can you see something below? Yes. This is your superior turbinate. I am taking away this part of the superior turbinate. Can you see? Yes. This is superior turbinate. The disease medial to it. See the septum, and at this level you can enter into the sphenoid. Easily. This was a child's play. Straightforward situation for the sphenoid. But whenever you look for the sphenoid in difficult situation, the landmark is this maxillary line. Never go above the maxillary line and go flush to the septum. Not flush to the turbinate. You can go into the one of the cell behind, go flush to the septum. It has to be in the sphenoid. If you don't go in the maxillary line, try to go up here. You can enter into the planum sphenoidal and a CSF leak is likely there. So there are always safety landmarks. This is the surgery of, landmarks.
So maxillary line is a...
Yes, you can, yeah. Now, yeah.
In cases where there is isolated sphenoid disease,
Yes.
so which approach is your preference?
Pure medial.
Go medial to the...
Pure medial. Pure medial. Now see, I have seen the sphenoid. Now I can accomplish my posterior sphenoidectomy staying anterior to it. Staying anterior to it, I can do any damn thing. Keeping my orbit as a lateral limit, I can remove all these cells. Staying anterior to the ostium, as my carotid and optic and all those things are never going to come anterior to the ostium. So we have discovered this sphenoid ostium as a safeguard. This sphenoid ostium is a safeguard that you are not going to damage anything if you don't cross this limit. Yes?
Supposing you have difficulty finding a sphenoid ostium which is close slightly into the lower side,
Yes?
can you suggest some tips and tricks in order to...
Yes. Number one, I have already told, number one, in any given situation you look for, never go above the axillary line, this maxillary line.
Okay.
Never go above, and use your suction periosteum sliding at the level of the maxillary line or below along the septum. Now I am removing this wall of the maxilla.
So Satish bhai, the previous teaching was that you form the coena 1.2 centimeter above the coena, or you go from ethmoid to infromedial give 1/3 of the superior turbinate, all these three landmarks, in place of that, you said that Magri line is the most reliable landmark.
Most reliable, always works. See, landmark, science is always evolving. If something works for you best and it's a God-given landmark, why not to exploit that? Now see, I have done post-sigmoidectomy,
Yes.
and now the last thing left to me, widening the sphenoid. Just staying to the anterior wall, not going deeper with any sharp instrument.
So in this also, if you are going laterally beyond the septum,
See the disease, see the mucosal disease, see the mucin. What? CRP is a non-specific investigation of bacterial, inflammation. So, in case you want to give antibiotics, see, this is not infective disease, this is inflammatory disease. There could be associated bacterial infection as well. So, in case you suspect bacterial infection,
and monitoring of the CRP.
yes, you can first of all judge where there is bacterial infection. If the CRP is normal, it rules out bacterial infections for that matter. See, I am widening the sphenoid,
Yes, we are seeing the landmark.
staying on the anterior wall, nothing inside. See the wide sphenoid now. See the entire skull base flushed. Now coming to the Dubé sir's question. If the patient doesn't do douching post-op, Dubé sir, having done this work, full house face. See this is full house face? See the optic now, optico-carotid recess. See, if you don't take this this sphenoid sinus as a landmark, if you keep on doing work inside, see, one can easily damage the optic now. Forget about, assume every case is on OD. Stay medially, widen the sphenoid and then go further. Now, coming to Dubé sir's question, in case this side is done, in case the patient doesn't do douching and develop polyposis, having done this kind of a full house work to the limits, there is nothing left for the future surgeon as far as the sinus surgery is concerned. See that?
Yes.
What you can do? You can start the patient on oral steroid for a while and debride, and then topical steroid will take care again to the mucosa. Because practically you don't need a formal sinus surgery now.
Yes, because you already.
So this you can mention in your consent as an indirect guarantee. I am not using the word guarantee ever in science, but as a sort of indirect, to explain the patient that having done this, if you continue with the douching as explained, you will unlikely to have this disease again. But yes, in case in some unfortunate situation, if you are not doing that and develop polyp, still you don't need a formal sinus surgery. See now the landmarks everywhere? Can you see the full house sinus cavity panoramic view?
Fantastic. Sir, do you advise any medication for seasonal variation?
No, that is allergy. See, that is a comorbidity. If you have allergy, you have to treat accordingly. Ringer, steroid mixed in ringer. Ringer is a much better, alternative to the normal saline. Ringer is more physiological as compared to the saline. It contains, along with the sodium chloride, the potassium and lactate as well. Pardon? No, not. See, in this disease, we want a good mucociliary activity. Washkar. Yes? Post-sigmoidal artery is generally not very prominent because it passes through the thick post-sigmoidal skull base. But yes, I showed you yesterday. You can anticipate that a few millimeter, 5 to 6 millimeter anterior to the optic nerve, which is more almost always visible.
Sir, if this sphenoid sinus is very deep, do you need any inferior widening also, inferior border widening?
Yeah. In case of doubts, in case of extensive fungus, there is no harm in doing that.
But sometimes when we take punch over there, there is a brisk bleeding.
Yeah, because the vessel running on the anterior face, that is the nasoseptal artery.
Right.
So in that case, you can elevate the
Flap.
flap first. Yeah, it depends. If it is a bony hypertrophy, you need to core out the bone. If it is a mucosal hypertrophy, then you can ablate that and you can do a posterior nasal neurectomy. Let me tell you posterior nasal neurectomy. Yes, let me tell you what is to be done for posterior nasal neurectomy. I showed you yesterday posterior nasal nerve. They emerge from the pterygoid bone, from the pterygopalatine fossa and come in the nasal cavity between this is middle turbinate attachment, can you see? And this is inferior turbinate. Now, just above the middle turbinate attachment here is the sphenopalatine foramen. Here, see this? Cobbleter. These nerves, they emerge in the vicinity of the sphenopalatine foramen and then they pass inferiorly toward the inferior turbinate through this flat area. Can you see?
Yes, area between.
In the mucosa. To ablate these nerves, what you can do simple. See, this is cobbleter. Don't need to look at these now.
Ablate this area.
Yes, as a whole.
Bilaterally.
Yes, bilaterally. See this? Rather than doing a video neurectomy, this is selective posterior nasal neurectomy, and it helps in tackling the turbinate hypertrophy as well. Hey man, yesterday I had shown you. I had even clipped to show you.
Sometimes, sir, the posterior most part of the inferior turbinate is very bulbous. So you need to cut it.
Yes, so I told you there are two types of hypertrophy, bony or submucosal.
Yes.
In submucosal, this posterior neurectomy will work, but in bony hypertrophy, you have to reduce it. This is coagulation only. Coagulation of the mucosa carrying the nerves in that. Now see, coming to the opposite side. Here we don't see too many, polypoidal disease medial to the turbinate. Don't see. See? Hardly any polypoidal disease medial to the turbinate. Yet turbinate is floppy. So here I am not in favor of partial resection. Because had there been disease medial to it, the partial resection will allow the steroid to reach the olfactory region. But here, since there is no massive disease medial to it, so I'll try to preserve the turbinate and do something else. There is no harm. No harm. But see, when it is not needed, you can preserve it. So that's why I told you there are various ways. Now see the middle meatus, very clear. Now quickly, inferiorly directed. See this? Until you reach the hard bone. This part now I will go quickly as we have already discussed. Anybody has any questions regarding the sinus disease, sinus surgery, please come forward. Any suggestion?
Bilateral
40 दिया करने हैं.
rejection of the middle tablet, there is no issue of any anosmia or any problem.
Inferior part is devoid of olfactory, mucosa. So in those cases, you can use another avenue through the sublabial route. You make an enterostomy. You use your trocar and cannula and make a 4 mm opening, and then pass your debrider through that and 70 degree through the nose.
So sometimes just removing the part of the inferior turbinate bone and just making the ostia a little more wider inferiorly, we can approach those volumes.
Yes, you can do that.
We have a risk to injure the nasopharyngeal duct also.
So why to disturb this physiology over here? Unnecessary. Once you have an option, there is no harm. See, in this sublabial region, just make a 4 mm puncture with a trocar, push your blade through it with a 70 degree visualization from inside, remove. The moment you remove the blade, it heals in no time, without any side effect. Now see, this is the upper part of the uncinate.
Yes.
I am going little quick. बंद हो रहा है यार. सक्शन का कर कुछ. Not really. That is not physiological. Because it has been now very well understood, the ciliary activity in the sinuses takes the secretion to the natural ostia. See, there's a part of the aganegi. I am widening the axilla. See this?
Yes.
That is the part of the aganegi. We have already seen our lateral limit. And quickly we will be in frontal in no time. Frontal, once again, the same exercise I will show you so that you will never forget. Point डालिएगा ना. Yeah, that is worse. That is very, very difficult to treat. And if you have, it's a revision situation. If you are in doubt that you are not able to give a patent opening, see the lamina laterally.
Yes, yes.
See the beak, the axilla, the maxillary sinus, and the bulla. I will take 70 here. So in that case, Kapila, if you are not sure, do a draft. Don't take a third chance for surgery. Draft has hardly any disadvantage. See now.
Yes.
What I am showing, see the level of the axilla. Over there, 120. So, see the level of the axilla. Oh, the long ball pro. This is the axilla section. Just to tell you everybody, simplest way of accessing the frontal. See, this is axilla.
Yes.
This is beak. This is the cell at the level of the beak. See the beak behind, I can feel the hard bone, hardest bone in this region. Hardest bone. Can you see the hard bone there? Where it ends. See this where it ends? What can be the simpler way to open the frontal than this? Tell me. Tell me. 60, sometimes 120. 40 will not work. 40 will not reach out. 60 may reach out. 60, 90, 120, whatever. So the idea is your landmark should be simplest one to be identified. Sometimes your landmark is so difficult to identify, then how to rely on it. See, simple. Anybody doing fast can identify the axilla. Can you see?
Yes, yes.
Then underneath the axilla, can you see the beak? How can you identify the thickest bone? You can't break it easily. And go behind where the beak ends in the frontal. Simple. I hope you agree with me.
Yes, yes, yes. Every day we are finding easier and easier landmark by you.
So I am flushing laterally here. It is not only easier, it is safer landmark also. Because when you are working far anteriorly, you are away from all critical structures. And you can flush it to the limit. See, my medial limit is terminate. See, I flush with the terminate. I can't go anything beyond that. My lateral limit, see the lamina? See the lamina? Reverse. I can't go beyond that laterally. See that? And now I will flush it with the posterior table. Flush this posterior table with the ethmoidal roof using my skull base blade. Reverse. See, this is posterior table and flush with the ethmoidal roof. This anterior most part of the ethmoidal roof is very safe. See the beauty of the reverse blade. Can you see the frontal and everything so crystal clear? Hello? This is our work we have done on thousands of FES. And our every single junior guy working is able to do this.
Actually, Satish, previously it was axillary flap, then Caroline window, then different types of other terminology. Now you have given the...
All those are good. All those are good. But why to make your life so difficult? No, I have no window. No window for that matter. See this?
Absolutely fantastic.
Skull base. Now, this is your bulla. This concept of intact bulla was earlier popularized by our own Dr. Sethi, who was yesterday with us. And see what a simple concept he has brought out. This bulla, the anterior wall of the bulla goes to the skull base anterior to the anterior ethmoidal artery. Keep this patent to keep the anterior ethmoidal artery protected. As simple as that. See this bulla? So in next probably 5 to 10 minutes I will be through.
And what is the next phase, sir?
Oh, I don't know. Dr. Khanna will tell you. Boss?
You were telling us that there is a JNA yesterday you announced.
Yeah, JNA, there are two interesting implants. One is a regular one. One is a cholesteatoma, subtotal peterozacmine implant, same stage. See the same gel foam pieces, you know, same gel foam pieces. reverse. Merocil pieces. You can pack, so again steroid and pack into the cavity. Day after, 40 reverse. Day after.
Soap with steroid solution
Yes,
or some ointment.
steroid. This disease requires steroid.
When boss you have done full septoplasty along with fat, in those cases I think the pressure over the
Can you see the anterethmoidal artery there?
yes, yes,
See the artery?
yes, very clear.
Yes, Rajiv, you were saying something?
But I was saying when we do full septoplasty also along with bilateral fat, what I found that even if we keep these balancing pieces like you have told, sometimes it keeps on losing again.
Yeah, see, that is the nasal secretion which can, which can weep, you can say, and make the packing wet.
And patient's attendant will come to you immediately.
Yeah, there is some bleeding. Chota.
It is better. Nothing should come out.
5 मिनट में होने वाला है.
Seen along the
क्या कर रहे हो?
septum that goes to nasopharynx along the anterior segment.
So once you have seen the anterethmoidal artery, that means you have done the anterethmoidal roof work completely, because anterethmoidal artery is the last landmark in the, or posterior most landmark in the anterethmoidal roof. See this once again. Can you see?
Yes, sir, absolutely fantastic. Very good.
Very clear? And now I will switch over to the 0 degree. That is the maxillary sinus. 0 degree. So last work for the postethmoid and the sphenoid. This sphenoid we know has a lateral recess. We'll show you that with the 70 degree. Transpterygoid approach steps. Okay. You are not supposed to enlarge too much inferiorly to avoid injury to the important vessel for the future flap. Yeah. Secondly, you can enlarge laterally till the lateral wall. Yeah, stay on the anterior wall. That's it. See this, the ethmoidal axis.
Have you ever used drug-inducing steroid pen or the
Yes, those are in practice. Those are in practice. Those are now FDA approved also. The first one was the Propel.
they are now available in India also?
Yeah, but I have never used the cost.
10,000 rupees.
No steroid stent is available in 10,000 rupees.
Stents are costly.
Now entering it, maybe I am not aware. See this? In the postethmoid,
Sir, can you tell me step by step what is the method of enlarging the sphenoid anterior wall?
anterior wall.
Maybe like opening, widening the opening.
Widen the opening, I just told you not to enlarge too inferiorly, superiorly, because you first put your punch to see that you are not beyond the limits, and then punch out. I will show you. Some polyp there, lower down. See this? lower down only.
So again, Satish sir, you are telling that we have to confine ourselves to the anterior border of the sphenoid sinus.
Yes, and see this.
But previous teaching
See
was that
this.
you can go inferiorly and medially.
See this, yes. The maxillary line.
Yes.
Go along the septum. You can widen medially to flush till septum. See this? Superiorly, you are not supposed to widen blindly because this is more close to the roof. Laterally, yes. Now, anything anterior to this sphenoid, I will debride. See this?
Yes.
And widen this sphenoid laterally to the lateral wall. That is what your question is. See why I opened up this area. Medial orbital wall. See this?
Yes.
Many a time we miss the Heller cell over here. See this Heller cell.
Yes.
What you need to do is remove this party wall and flush with the maxillary sinus. Whatever, till the cell wall is flushed. See this? You have to flush this with the maxillary sinus. See that? See this? See the Heller cell? One can easily miss if this orbital angle is not seen. Can you see this? Now this is flush with the maxillary sinus. I can see the sphenoid ostium behind. Anything anterior to it, I can see my anterethmoidal artery anteriorly. That's the postethmoidal skull base. This is all postethmoidal skull base. Lateral limit is lamina pepracia. See that?
So do you join the both sphenoid sinus also posteriorly?
No, why? See, all this postethmoidal roof I am tackling is staying anterior to this opening. See this? See this? It's staying anterior to this only. Blocked. Which cell? Retromaxillary cell, people describe, is basically a lateral recess of the sphenoid. I don't know if any had such fancy name. See now what I have done. I widened the sphenoid a little bit to the anterior wall, not inside. See this disease? Mucin.
That is why the inferior opening is required or not to flush with the.
See this? Now the medial orbital wall completely flush this Heller cell. This is important. One can easily miss this Heller cell. Now, your question was asking about widening the maxillary, the sphenoid wall. Give me Carison. I am widening it laterally. Punch is always a safe instrument because you define your safety with your prong. See this? Give me 40 blade. And then I will show you lateral recess. The last thing to show you is the lateral recess. See sinus surgery done on this side. One there. So this side, you can see the full house cavity now. Hello? We knew there was a lateral recess this side. This is going behind the maxillary sinus. Let me show you. 70. And the rest of the job is done. See, I am going with a 70 like this. Rotating the cable. Find all. Yeah. See the lateral recess there.
Yes.
See the lateral recess there.
Yes, sir.
लंबा वाला देना ये.
So lateral recess means pneumatized, clinoid.
Oh no, no.
Pterygoid.
Yes. Pterygoid process. See this lateral recess? Can you see this lateral recess in the sphenoid?
Yes, sir. Very clearly.
That is the far lateral recess there.
Yes.
See this? Pretty clear. 0. So this side job is done. And now finally I will bulgarize the turbinate on this side. I told you I will not resect since there is no disease medial to the turbinate superiorly. And see this? This turbinate?
सतीश सर,
Yeah.
एक बार फिर स्नाइड साइनस में सारे लैंडमार्क को पॉइंटर से दिखा दीजिए.
दिखाता हूँ.
ऑप्टिक कैरोटिड, ऑप्टिको कैरोटिड रीचेस.
See this, I am making this septum raw.
Yes.
See just mucosal surface. See this? Opposing area raw and just keep them like this to invite adhesions. That is bulgarization. Wash. Could you see? Such a simple process will keep our marrow cell for a day or two and it will invite the adhesions. Dal pani. Now finally in the sphenoid. Yeah. Yes. Give me a count function. 40 there. Late 40. Sphenoid, since the mucosa is hypertrophic. See this? But what I faintly see here, that's the prominence of optic nerve. That is plenum sphenoidal. That is optic now. That is the opticokerotic recess here, and that is the prominence of the sella. Since the mucosa is hypertrophy, you can't make out much.
So sir, ये जहाँ pituitary, where you do the pituitary just below the optic chiasma,
Yes. Below the optic chiasma is tuberculum sella.
tubercle cell, or above it Schwann cell.
Yes. And below the tuberculum is the pituitary fossa.
Okay.
So my pituitary fossa is right here, because this is the opticokerotic recess here. Now for the transpterygoid, see, this is our recess here behind. We have seen there. So in order to go there, you have to remove this sphenoid wall, this entry wall of the sphenoid. See this?
Yes.
Elevate this flap, remove this entry wall of the sphenoid, remove this medial part of the posterior wall of the maxilla. Behind that is pterygopaltine fossa, the sphenopalatine artery. Most of the time you have to clip it. And behind that is a thin pterygoid bone now, because rest is pneumatized. So you have to remove this almost 1 square centimeter chunk of bone. See this?
Yes.
And then here would be your, see, that is your lateral recess, would be here directly in front of you. Anything else you want me to show on this? Okay, again the posterior nasal neurectomy. Give me the first cobbletter. See, let me show you first the middle meatal enterostomy here. See this? See the inferior turbinate, middle turbinate both?
Yes.
This is the region of the sphenopalatine. See the posterior wall here. That's the region of the sphenopalatine foramen. That's the region of the perpendicular plate of the palatine bone. All the nerves are coming from here and going to the inferior turbinate. So all these mucosa, where the nerves are going to the inferior turbinate. See this? Yeah, sphenopalatine is few millimeters above the posterior edge of this turbinate attachment. So to me, the sphenopalatine would be right there. Let me show you. It will be right there. Yes. Yeah, turbinate attachment. See this. The artery is coming from behind this wall. Coming here. This is the inferior attachment of the middle turbinate, and roughly it is here. See, I can feel this cresta, this bone behind this bone. I can show you if you want, finally.
Yes.
Okay. Okay then. Why to keep the confusion? I had shown again and again yesterday. Anyway. Can you see this bone cresta? अच्छा Yeah. That is the vessel. Just above the cresta. That is the vessel.
Yes, sir.
See that?
Yes, yes, sir. Very clear.
वो लेके जा, section लेके जा वहाँ. Above. Short. That is the vessel. That one.
Yes, sir. Yes.
See the level? That's the turbinate attachment roughly here. I can cover this. Leave it. Okay? So we come to the conclusion of this case.
Thank you, sir. Very nice demonstration. Big applause for you, sir.
Thank you. Thank you so much for your patience. And
We enjoyed every bit of it. And there are so many concepts which was there previously in our mind. It has now become very easier with your demonstration. And we learned some new terminology also. Thank you, Satish.
thank you, sir.
Just connect the one.
Sir, there is a question. This floppy turret already you have baptized, no?
Yes, sir.
खन्ना सर अगला case क्या है?
Hello.
खन्ना सर,
Yes, yes. Hello.
what is the next case, sir?
Hello. Next case is ear surgery. She is a lady
Yes, sir.
having a central perforation with tympanosclerosis. Not very large perforation, small perforation is there, small to medium, and having mastoiditis in CT scan. So we got the CT scan done, which will be described by Dr. Satish. I have already taken the graft.
And what is the hearing status?
Just give me some time. She is having moderate hearing loss, conductive on right side, and left side is normal. Dr. Satish? It is a dry central perforation with mastoiditis. फोन देना कौन है
safe chronic suppurative otitis media having a central perforation, some tympanic sclerosis probably. And since CT was done, so I was just going through it. Though in safe otitis media, it is not mandatory to get a CT scan done, but it gives you certain information. You see, in CSOM, the kind of information, CT temporal bone has to be looked differently for different pathology. Like for otosclerosis, for cochlear implant, we look at differently for different information. Here, in a safe otitis media, what all positive information we can get out of this is, see the ossicular chain looks intact. Can you see? Yes. See the stapes? See the stapedial arch?
Yeah, we can see what.
The incus and the malleus. The atic looks clear, and the only thing is this editus and the antrum has opacity. Could be blockage, could be mucosal blockage, could be tympanosclerosis, fibrosis. You cannot differentiate, but there is something giving the picture of mastoiditis. See this? So the mucosal edema is definitely there, and that is that substantiates our proposal. What we always do is to explore the mastoid to see the editus patency, which we are going to see this in this case. So we are going to do a tympanoplasty. We call it middle ear cleft reconstruction, looking at Eustachian tube, middle ear, grafting the middle ear, seeing the ossicular chain, then opening the mastoid to see the patency of the editus. So because all these cells is aerated down the Eustachian tube. Pardon? Yeah, facial nerve course looks good. Let me show you. See, this is the intra-auditory meatus. This is labyrinthine segment. Can you see? Yeah, you saw yesterday this labyrinthine segment in relation to this. This is basal ton. See, this is superior to inferior. I am going. This is axial cuts, superior to inferior. See the first appearance of the basal ton. Can you see? And see the relationship with the labyrinthine segment of the facial nerve. Yesterday I showed you this upper basal ton. This is uppermost as we are going upside down. This is the uppermost part of the basal ton. How it is in close contact with the labyrinthine segment of the facial nerve. Then this is first genu. This is the horizontal segment of the facial nerve. Can you see? This is the second genu. Medially the sinus tympani looking clear. And then you can follow this nerve right to the stylomastoid foramen. That is the stylomastoid foramen. See this facial nerve, facial nerve, facial nerve. So this is how you can see the facial nerve. So basically this is a perforation with mastoiditis. It look like could be mucosal hypertrophy or whatever in the antrum, maybe editus blockage. We will explore that. The ossicular chain looks intact, so will require only tympanic membrane grafting most likely. So this was just to, since we were having CT scan, so I went through it. Otherwise the situation is straightforward. Do we go ahead? So our protocol will be the most likely the same one. Let's see the perforation for the interlate tympanoplasty. एनाल्जेसिक भी तो है, एनाल्जेसिक भी तो है. और सब अच्छा, कभी आप लोग क्लोनिडीन यूज करते हो फेस में? चल रहा है क्या? पिक्चर जा रही है क्या? हेलो 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 हेलो. या इधर इधर उधर जा रही है आवाज. Yeah, yes. Are you getting the picture? Okay, I thought you're not getting. So this is a large perforation, you can see. I have just made the margins raw. Those are a part of the any tympanoplasty procedure to facilitate healing. Though the technique which I am going to show is the interlay, wherein we are going to separate the tympanic membrane into layers. Dr. Khanna had already started this case and he has already harvested the graft as well. So my standard flap for tympanoplasty is, see this, that's the superior margin of perforation, posterior superior margin. Hello, 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 am I audible? Hello.
Yes, sir.
See, my incision is few millimeters above the posterior superior margin.
So can you focus that?
Yes, is it not focus?
No, it's centralize it, sir. Just
किधर आ रही है पिक्चर? जा रही है कहीं? Let me know when it is centralized now.
yeah, it's okay now.
Okay?
Yes, okay. Yes, sir. Can you zoom out a little, boss?
Zoom out.
Yeah, it's okay then, right?
Yeah. So this is the superior margin of the perforation. See this? This is my superior incision few millimeter away. Can you see?
Yes.
That's the inferior margin and this my incision is not reaching up to the,
The annulus.
yes, because I need to make it circumferential few millimeters lateral to the annulus to do interlay. Interlay means we'll separate the tympanic membrane into layers.
Yes. So we can see there is some TS plaque also on the residual TM.
Maybe we'll see.
So
Once we
centralize the distance.
see, once we separate in that plane between the mucosa and fibrous layer, if there is any TS plaque, will automatically come into picture. That is always in that layer. See this?
Yes.
And now I will circumferentially convert this to elevate the entire tympanomeatal flap. See this? This anterior flap is little relatively thinner. So this is the important procedure for our junior colleagues.
Very, very thin anterior flap.
Yeah, you can quickly, staying bang on the bone. See, I can reach out to the level of annulus in no time.
Yes, we can see the
Patla de, patla de. See, to the level of annulus. That's the annulus. See that?
we can see now.
Yes, sir. Focus. Actually, I don't have a screen here whether I am, that is good for you or not, for how the focus is going. Now coming anteriorly. This anterior superior incision is going to go few millimeters above the anterior superior margin of perforation. So that my incision and flap will be everywhere beyond the margins of perforation. See that? See, no time it has been raised. Not join. In case required, you can without any problem. Now, do I increase the magnification? Yeah. How is this magnification? Too much?
Little too much here.
Okay, वो the right angle. Okay, let me reduce. Now, is this fine?
Better now. Picture is blurred, somewhat blurred.
Blurred? Mine is clear. See, this is inbuilt camera in the microscope. You can't do anything, but I have a good picture here. Really, is it blurred?
It's okay, boss.
Okay. See, this is the annulus anteroinferiorly.
Yes, we can see.
I'll hug my, right angle hook. See this?
Yes, yes.
And elevate, leaving this mucosa below. Can you see?
Brilliant.
This interlay means elevate this mucosal and the fibrous layer. This annulus is condensation of the fibrous layer.
You have this blunt right angle shape now.
Yeah, not exactly right angle, but yes, blunt angled hook. This is for this purpose only. See some tympanosclerotic plaque coming?
Yes.
See this?
Just थोड़ा focus. Yes, sir. Better, sir.
See this tympanosclerotic plaque? If there is any tympanoscleral, will automatically come in this layer. And see, this is anterior-superior tympanosclerosis. No other technique would give this access, this good access to the anterior-superior plaque. You have full access to the anterior-superior region. See this? Can you see this plaque? And you can remove it easily. See this? What's up? See this? And see this? Wherever is tympanosclerosis, you can remove it. Simple. And yeah, that is the final tympanosclerosis. Can you see? Now, if I deposit everything back into the place, see the picture. I have separated inferiorly, anteriorly, anterior-superiorly. Only the posterior part is left. See this? See, this contains two layers except the mucosa. Circular. See this? Annulus. So you have to literally peel this annulus off the mucosa. You are not supposed to cut it. See this? See this? Peel this annulus.
A little bit focus required.
Again, some focus is required. Let me see scissors. Because here the microscope is not in my control. See this tympanosclerotic plaque behind as well?
Yes, boss.
See, wherever tympanosclerotic, it is going to come in the same plane. So we can't leave any tympanosclerosis behind with this approach. If it is going to come in the way. Yes, see this?
A little bit centralized.
Centralize. Okay. I have elevated all over. See the ossicular chain I am focusing at. Some tympanoid sclerosis on the promontory as well. Yeah. See the mobility of the stapes.
Very well, sir.
So by and large, we have elevated the circumferential flap. We have separated the flap in layers. The two layers we have elevated. See this? And the mucosal layer is left behind as a bed. As a bed for the graft. See this? And in between these two layers, we are going to place our graft. I hope it is clear.
Yes, sir. Sir, if somehow we don't remove the, we also remove the mucosal layer, not, we don't do the interlay, then how much advantages or disadvantages is there?
See, interlay means you are placing your graft in between the layer. So it divides all the complications of underlay and overlay, number one. Underlay, your graft can fall, all that. Nothing is going to happen as it is between the layers. Only all those complications of, only your graft can, you can leave the epithelium behind, all that can be avoided. So all the complications of onlay and underlay are avoided, and you place your graft in the most physiological plane between mucosa and the fibrous layer. Yeah, how to focus? For me it is focus. पीछे है क्या? अच्छा पीछे आ गया क्या? अच्छा. Now I can see behind. Better now? So now two things left for me. Though the physiological patency of the Eustachian tube is ascertained to a certain extent by the tympanometry test, you can assess both the ventilatory function and the mucociliary function of the Eustachian tube. See the Eustachian tube there? Can you see?
Yes, sir.
Flush. Here what all I can do, because in long-standing perforation sometime you may have foreign bodies lodged because of the infection, because of the mastic use, whatever. So I can flush it. Simple. You have checked the ossicular chain. Dr. Khanna has already harvested the graft, though generally in my practice, we harvest a fresh graft immediately before the surgery, immediately before the need, bed-to-bed grafting. But anyway, you can use the wet graft also. He has harvested, but we have kept it wet. So now the most important thing coming to ascertain is the patency of the editors which is required for aeration of the mastoid air cells. See, if we ignore this fact and graft, it may result in failure. Hello?
Yes, sir. Yes.
So it is always better. This is one of the most rewarding surgery, and we should do all this to, rule out any possibility of failure. It doesn't take time. If it is not blocked, you will find patency so early.
Yes.
Okay?
Yes, sir.
So if it is not blocked, you will find the patency so early. My landmarks are same. See the spine of Henle anteriorly, the inferior temporal line behind, Still not found any patency. So I'm planning to go deeper. Sickle. See the thick mucosa inside. See, no patency. So now this is a great case to show how to achieve the patency. See this? I am going towards the editors, anterosuperiorly towards the editors, at the same time thinning the canal. Now in this situation, suppose if you graft with this blocked editors, then it may not be a successful procedure. Yes, now you have to achieve patency. See the tympanosclerosis. No, no. ये diamond है ना क्या actually? See this lot of. See this little lateral oozing. What you can do? Okay, dry diamond. See, run the dry diamond. It stops. See the oozing stopped. Who is the cutting? Sickle. Now I will slowly reach the level of the editor. See such a thick mucosa. Yes. Now, no, tympanosis cannot be differentiated on CT scan. CT scan, all opacities are same. घूम रही है. You cannot differentiate into soft tissues with CT scan. एक बार diamond देना एक बार. See this little oozing laterally. Now? Yes. Dry. Oh, yes. Now? Now see, this is the level of the lateral canal. Slowly go anteriorly. Keep going anterosuperiorly and anteriorly into the canal. नहीं चल रही यार सेट वही. Some abnormal bone. This is some abnormal bone. लंबी है ना पर. No. This is some abnormal bone. Little bit of fine focusing. So I will reach to the editors, will see the incus. चल ही नहीं रही यार. घूम रही है पर. और डेंजरस. पतली देना यार. You can compare the level on both sides. अरे गाइड अंदर नहीं जाती यार, ये गार्ड है इसका. You have to completely clear the editors. That is the challenge. घूमी दे
Sir, if there is some doubt from the posterior approach, can we go from the anterior part of the attic into completely inside out?
क्या कर रहा है यार चलिए दीदी Yeah, anteriorly, there are indirect ways, A lot of people try the endoscope to look at the editor for patency, but see, there was a tympanosclerotic plaque behind. Your endoscope could have easily missed. So all those are indirect methods, not direct ones.
No, sir, drilling the posterior superior canal from the inside,
Yeah,
we can.
but you can't see beyond the editors then.
Yes. So from both the ways, if we can drill from inside also and from
Yeah, I may require a drilling from inside also. I may require drilling from inside also. पतला देना क्या चक्कर हो गया तुम्हारे ड्रिल को लगा लो keep thinning the canal as you go anteriorly. See this? See the thick mucosa, and I got the patency. I will widen it further. See the thick mucosa, patli drill, or the patli drill. This is the bony, obstruction laterally and then mucosal hypertrophy. See this mucosa?
Yes.
Now it is patent. But I will get a free flow. Yes, now it looks like a free flow coming. I can see the media.
We haven't yet seen the input, right?
Yes. Even I have not seen, I have not focused. I am still far behind. The obstruction were far behind only. See this? See this?
Yes.
This is the area behind the editors. Now watch there. And there was a thick tympanosclerotic plaque which was blocking, which I have removed. And I got see this?
Yes, sir.
I will show you the free flow. See the free flow. See this is the same level?
Yes, sir.
See this?
Yes, sir.
That is free flow. And see the most importantly, that mucosa in the floor of the editors is good, intact.
Yes.
If I remove this bone, my incus is here. Yes.
Can you, sir, show us that?
Yeah, I need to drill this bone. See this glimpse of incus here. Let me. No need to remove since we got the patency. No need to remove. But that is a glimpse of incus.
Sir, sometimes when there is no ossicles, there are no ossicles, and we need to achieve the patency. So, what is the landmark for that? How much drill we should drill?
Then, when there is no ossicle, then there is no problem. Then there is nothing to, damage. When there is no ossicle, just follow the lateral canal. Stay in the floor of the lateral canal. And just go ahead. Yeah, once the ossicular chain is intact, you are frightened to damage the intact ossicular chain. See my perforation? See my perforation?
Yes, yes, very clear. Yes.
See, everything clear?
Yes, sir.
Now is the time for grafting. See the ossicular chain there. Again, see the patency, integrity is good.
Yes, sir.
ये cotton ball देना है. Now the final time is for
Sir, one question.
yes, please.
Sir, any tip required to prevent the facial nerve injury while looking for editors?
Yes, that's the important thing. So the best thing is stay close to the tagman.
Sir, can you show it in the mastoid region?
See, stay close to the tagman. As you stay close to the tagman, you are high up from the lateral canal. If you are not oriented, your drilling is inferiorly directed, you can injure the lateral canal and the facial canal. And we have got couple of cases also where the facial nerve was injured during this procedure. So be careful. The only point we always tell is stay close to the tagman.
So drill anterior superiorly close to the tagman.
Yes, always close to the tagman. That is the bottom line. If you stay close to the tagman, nothing is going to happen.
The fine focus.
So now I am just looking at the bed, if any oozing or something, so that we can graft further. Give me a cotton ball. Small ooze is there. I don't want a ooze to be there for a hematoma to form between the flap and the bone.
And in Bell's palsy, doing unrecovered facial nerve palsy, which part do you decompress facial nerve?
See, in Bell's, if it is a proper Bell's, it is mostly the labyrinthine segment which is, compromised. And without decompressing the labyrinthine segment, in case you are operating, is a joke. Now, in order to see the labyrinthine segment is always a challenge from the mastoid side. But your CT scan can tell you whether it is accessible from the mastoid side or not. CT scan will tell you how high the tagman is, how the facial canal in relation to the tagman is, the labyrinthine. In favorable condition, you can access to the mastoid side. And secondly, if your semicircular canal is coming in the way, because superior canal is something which is the obstacle if you go from behind, you can come from anteriorly by the transzygomatic approach. Same thing to the canal. Rather than I am sitting behind, I have to come from anteriorly. So my superior canal will not come in the way.
There is no need to decompress the vertical part.
No, that is never a culprit. And if it is unfavorable, then you have to go by middle fossa approach. So now the final part we have reached, that is the grafting. In interlay, The grafting is never difficult because you have to spread the graft on the bed. See this graft? Hello?
Centralize the picture, please.
Not centralize? Just a minute.
Yes, sir.
See this graft? First is advancement. Advance anteriorly adequately to come over the anterior canal wall. See this?
Yes, sir.
Push it underneath the malleus. See this?
Yes, sir. Yes, sir.
And thirdly, spread on the canal.
Yes,
Edge to edge. See that?
yes, sir.
Now reposit the posterior part. Only posterior part.
Okay.
This posterior part you can make one unit, the graft and flap. They become one unit by surface tension. See now?
Yes, sir.
So now whatever manipulation you do anteriorly, it is not going to,
That is why you use wet graft or fresh graft.
yeah, to take the advantage of surface tension. See now?
Yes, sir.
Now elevate the anterior flap, elevate it completely and take your graft right on the bed. See? Place it on the bed like this.
Yes, sir.
Place it thoroughly on the bed and deposit your anterior flap.
Sir, you put it inside the annulus area?
Yes. Once I place it thoroughly, then we'll tighten from the periphery.
Oh.
See this.
Yes, yes. The instrument which you are using, what is that?
A simple TM repositor, blunt one.
Like
See this? Everywhere
yes, sir.
my graft is between two layers.
Yes, sir.
See these two?
Yes, sir.
See, I don't keep anything in the middle here.
No gel box, sir?
No, never. Why to unnecessarily block the pathway to the editors? See the posterior layer? Similarly, you can check all the layers. See this graft? Graft and flap. See this? Elevate this graft and flap. And this is mucosa. See, this is the blood which I don't want. See, whatever is going to happen in initial first 10 to 14 days. It will set in. Till then, you can give broad spectrum antibiotic. See this? Completely under vision setting. See this graft? Anterior superiorly also you can elevate and check. Everywhere the graft, see this graft? Graft is behind the flap and the mucosa is there. See this? You just deposit these two units over the mucosa. Simple. So now the grafting becomes the simplest job because you have a bed there. Tighten at the periphery, what you are asking. See this? Tighten at the periphery. And now I have this, what I will do now. See again, if I elevate, see this graft? This graft is sandwiched all around between the layers. And see, this is the middle ear space. See, this is mucosa over which the graft is sitting. See that? So my graft is sandwiched between two layers above and the mucosa below. Okay? And finally, I am going to use some gel foam. I will mix this gel foam in the blood available in the field. First in the periphery. Periphery to the important areas. Antero-inferiorly, antero-superiorly. See that?
Yes.
Again, check your middle ear space. Final. See this good? See this?
Yes, sir.
Just I am placing at the periphery. This is advancing epithelium.
So, one new concept or new surgery like total annular excision with implantation. What's your opinion?
Yeah, so that is the same idea. The idea behind that is the problem of mucosa. See, in underlay or any other technique, if you leave the mucosa above the graft, that can keep on weeping, invite infection and post-operative troubles. So in order to prevent the mucosa, ensure that mucosa cannot come, the entire annulus along with the tympanic membrane is excised and the canal skin then comes over the graft. So this is again a technique to 100% ensure that the mucosa doesn't come. But that is a, lot of change in to the physiology. This is very well popularized by our own Dr. Suri Prabhu, Sudeep Munjal, a lot of people are doing and claiming good results. I don't know with so much of physiology change with the annulus removed, how are the long-term results going to be? But since they are doing, must be good. But never done. But this technique is, same thing. We endorse their concept that the mucosa should not come above. And in interlay, same way, a graft is above the mucosal layer all around. So mucosa cannot come. And we find this is more physiological. We have done thousands and thousands of cases with amazing results. So no doubt about it. Still we are open. But this is...
Do you wait for ears to dry before...
not really, unless there is some acute fulminating infection.
Some granulations are there, then...
Some, discharge but not looking like fulminating one. Some mucosal discharge, all these things are not contraindications. Yeah, after few days, what you can do, you can apply an antifungal pack for 4 or 5 days, and then you can do. Because what we pack in the canal here is the ciprofloxacin steroid combination. And we don't want to use this in the already fungus there in canal. And it works very, you can put some quadridrum or something pack for 4 or 5 days. It takes care of fungus, the canal becomes dry, and then you can. But mild inflammation, mild mucosal discharge are not contraindications. Rather, surgery helps in eliminating that once you open up the adductors and give antibiotics later on.
And how to deal with the post-operative weeping?
Post-operative?
Weeping canal.
Many ways. First of all, culture-directed antibiotics. And if granulations, then you have to cauterize them. You can pack with a steroid or antibiotic solution. If it is fulminating infection, we sometimes pack with manuka honey. It works like magic. So many ways. It depends whether it is infected or not.
Do you use any dry preparation to pack layer?
Yes, yes, Neosporin H sometime. If there is minimal overall generalized inflammation in the canal, you can apply. We leave and start eardrops over it. You have to buy from New Zealand because that is not medicated honey. On Amazon is not medicated. It is quite costly. You have to buy from New Zealand. It's amazing antibacterial. Wherever the infection is not coming under control, you apply manuka honey. Lethal to any bacteria. Bacteria, fungus, whatever. We use extensively in mucotymes also, in the cavities.
And what about Castellani solution, which is very well marketed by Mumbai?
Which one?
Castellani solution.
Casti?
Castellani solution. It is phenol and
No idea.
our Mumbai colleagues.
I have no idea. Earlier people used to use aluminum.
Violet color solution.
Earlier people I remember used to use aluminum acetate solution. Epithelialization. See, if the cavity is adequately saucerized, good meatoplasty, and no infection, it epithelializes fast. If anywhere is problem in the surgical quality, in terms of not adequately excentrating the cells, high ridge, narrow meatus, all those issues and infection, they all those give problem like a persistent discharging cavity. So once you are doing a canal down, it has to be a adequately well done canal down. Excentrate all cells, give a good meatoplasty and all that, not leaving the raw areas, rather put the vascularized tissue from behind. From behind the ear, there is a lot of vascularized tissue. Rather than leaving a bare bone in the cavity, bare bone is going to invite infection. Ear drops or better in cavity, you can pack antibiotic ointments. That is much better option to keep in place for some time. Ear drops, they come out easily. They don't work much.
Now people are using mometasone cream for red angry canal wall.
Yes, steroid. So you can use antibiotic steroid combinations also. The Neosporin H has an antibiotic as well as steroid. And the best part is it is effective against Pseudomonas.
And sir, what about using vinegar?
Yes, that is also. So we use in cavities, I forgot to tell you, in cavities to wash out the cavities. They give patient 1-2% acetic acid and ask them to rinse the cavity. And it works very well because it acidifies the entire medium to prevent bacterial growth. So it is very good. For like you have a mastoid cavity, not very angry, not very infected, yet to heal, little bit inflammation, which can acquire infection, it is best. We tell patient to rinse the cavity, fill up the cavity completely, lie down, fill up, and then rinse after a minute or so, twice a day. But it is very good. And it somehow, I don't know, it helps in epithelialization also because it is irritant. Yes, in perforation, yes, it is always good to assess to prognosticate. See, There are two functions of eustachian tube. One is ventilatory, another is secretory. Mucociliary function, sorry. So ventilatory function means almost every minute, every other minute, the eustachian tube opens and drives the air in the middle ear. That air in the middle ear is absorbed by the mucosa, the blood in the mucosa, and as the blood is absorbed, constantly the pressure is decreasing, normally, in normal physiology. So, every time as the pressure decreases, eustachian tube drive air. The pressure decreases, eustachian tube drive air. That's the normal physiology. And every time when the eustachian tube, pharyngeal end pumps, the air contained in the isthmus is driven inside. So that is almost 2 microliters. That's how our eustachian tube opens 1,000 times a day almost, and 2 ml of the air is delivered every day in the middle ear, overall. That 2 ml air every day is vital to the optimal functioning of the eustachian tube. Now, how can you assess this? Tympanometry. You know, in tympanometry, you seal the external auditory canal with a probe. In a perforated ear, the middle ear is now communicated to the exterior only by the eustachian tube. Now, you raise the tympanometry pressure by the pump, or raise or reduce whatever, plus, minus 400, whatever extreme pressure, and ask the patient to swallow. If the eustachian tube is adequately functioning, with every swallow, the pressure will equalize towards the normal side. If it is positive, it will come down towards zero. It is negative, it is come up towards zero. So with every swallow, eustachian tube should open and neutralize the extreme pressure. Now, if it is adequately functioning, it will neutralize. If it is malfunctioning, it will not completely neutralize in spite of repeated swallowing, multiple swallowing. If it is non-functioning, there will be no change. So at least you can have idea that eustachian tube is absolutely non-functioning. Yes, you can prognosticate. Patient will ask you, how will my surgery fare in the post-op? Nothing is in your control, because whatever surgery you are doing is a mechanical procedure. The physiology of the ear is something you have not seen. There are a lot of nasal causes, eustachian tube causes you have to rule out to, prevent problems. That is mechanical patency. It is the physiological patency which is required, not mechanical. Mechanical opening of the eustachian tube is never something useful. It is the physiological functioning of the eustachian tube which is important. मशीनें बहुत आ रही हैं, but they may not be useful always.
Then what to do in those cases?
So those dilate the cartilaginous eustachian tube. They go up to the isthmus, the dilators, with unpredictable outcomes. You dilate and leave it. Now what is going to happen, you never know.
Then again we will do your test.
Huh.
Whether it is
So the natural physiology of the eustachian tube cannot be ascertained with that. I told you that 2 ml of the air driven every day by more than 1,000 time openings is the key to the optimum middle ear functioning. So it is like our lung and trachea. The middle ear is like a lung and the eustachian tube like a trachea. So this ventilatory function is very important.
Sir, so can we, Valsalva is useful to maintain this air into mid-ear cleft?
See, that can be useful for the time being. You cannot do Valsalva 1,000 times a day.
then what you advise to your patients who are having this kind of atelectatic tympanic membrane or with adhesive hepatitis media?
Give them, rule out the nasal cause first of all, why eustachian tube has gone malfunction, mostly nasal causes. Many of these patients allergy, sinusitis, many patients have cleft palate, so many other issues, adenoids, this, that. So that is the indication for ruling out the nasal cause, number one.
Okay.
Number two, the only thing what we have seen which works is the decongestant and steroids, topical steroids. So we advocate them nasal sprays for long term. You can call them again and check the function. If it improves, then you can go ahead. Or sometime you go ahead, graft, it may work. It's not absolute contraindication. It may work, but it may not work in long run.
So in these cases,
Because the negative pressure can develop later on.
so in these cases, we can use sliced cartilage in place of regular embolization graft.
No, that is never an
Because
answer.
that will give more strength for interaction.
See, if the negative pressure is developing, Hello. Yes, sir. So actually, this is a young patient who had undergone hemithyroidectomy a few years back and now has a solid cystic nodule. Solid cystic nodule in the left gland. FNH is inconclusive, maybe Bethesda 3, what I was told, and quite big, giving a deformity. So our plan is left hemithyroidectomy. And in thyroid, the initial imaging investigation of choice is sonography. Ultrasound is the investigation of choice for many regions. And since this patient had MRI, so I can run through the MRI certain important information. See this, the most important thing in the MRI is solid cystic nodule. Solid cystic nodule is always something should be closely followed. This is the cystic part in the nodule and in the solid part in the nodule. See this?
Yes.
Though we don't have diffusion, we can't demarcate whether it is benign or malignant. But the cystic part is very well lined, uniformly lined cystic part. And the rest of the nodule is the solid one. So plan is hemithyroidectomy, investigation of choice. Initial investigation is always ultrasound, then FNA. And most of the time you don't need CT or MRI unless there is malignancy and you suspect the great vessel or airway involvement or retrosternal involvement, then only the MRI or CT scan is indicated. Otherwise, most of the time you can get away with ultrasound, FNAC and thyroid hormone testing.
This patient has ultrasound or not?
I don't know. What I have been given is this one. Ultrasound.
We will not be able to see microcalcification, etc. in this MRI.
Yes, that's why ultrasound is the primary investigation of choice for many regions. And having a good sonologist can tell you up to 95% accuracy if there is any suspicion of malignancy on ultrasound. There are certain ultrasonic features we can tell you about the possibility of malignancy. So here is the surgical exercise to demonstrate. Our colleagues have already raised the flap and I'm going to share you with the steps of the surgery. Thyroid surgery is always fascinating, which requires extreme diligence to preserve a lot of neurovascular structures and parathyroid glands. So the 3 or 4 structures which are more important to preserve are the recurrent laryngeal nerve, external branch of the superior laryngeal nerve, and most importantly, parathyroids. And here, the edge comes from the microscope. Microscopic surgery has definite edge in identifying and protecting these structures, which is I am going to share you again.
What was the previous biopsy?
It was benign. Yeah.
Hello. Incision has been given and the flaps are being stitched. Satish will join in few minutes. This is the external camera. They don't do. He will describe. Incision has been given already and that has been done by assistant. just to save the time. So this is the microscopic picture.
माइक वो लगा ना माइक हेलो हेलो Okay. Are you getting the microscopic picture, sir?
Yes, we are getting.
So I told you this is a solid cystic nodule.
Yes.
This is the midline. The opposite, hemithyroidectomy has been done earlier.
Yes.
Can you slightly zoom out a bit?
Probably this is the lowest one in this microscope.
You can give the orientation superior, inferior,
Okay.
lateral,
Okay.
medial.
It's too big a picture. See, this is superior, this is inferior, this is right side, and I am here on the left side.
Right.
So this is superior.
Okay.
Ajay. So I am elevating in the midline.
Okay.
How come? Since it was operated earlier, so you can imagine.
There will be a lot of fibrosis.
Yeah, expected. Normally, you have two layers of muscles. Stap muscles. The lateral one is the sternocleidomastoid and the medial one is the sternothyroid. Here I am dividing the muscle, looking at the situation.
Okay.
We can resuture it any point of time later. See, whenever you divide the muscle, always divide in the upper part, because their nerve supply is always from below, by the lower division of ANSA, lower loop of ANSA.
Yes.
See all this fibrosis in the muscles. So far I am elevating only the muscles. Can you see the cystic part of the nodule?
Yes.
See what I have reached underneath the strap muscle. Can you see?
Yes.
On my side. See this? I am reaching underneath the strap muscle, bipolar. With the pedal. You elevate the strap muscles, go underneath the strap muscle in the paratracheal plane. That is relatively avascular plane. The bipolar is not on. Okay. So now see this underneath the strap muscle. Open up the plane and elevate the gland out and reach in this paratracheal gutter. Can you see this? Yes. That is the most important part of the surgery, I believe, to get into the right plane. See this? Yes. See the big nodule coming out? Yeah. And see the plane. That is most important, to reach into this plane. Once you reach into this plane, your life becomes easier to identify the important structures. See this? The first thing I intend to identify once I reach. Most of the time, if you are in the right plane, you don't need to look for structures. They come automatically, become prominent to you. That's the carotid artery, you see. This is the lateral plane part of the muscle cut. I am opening little more, inferiorly, because my inferior dissection is always, important to start inferiorly. I'll tell you the reason behind that. Now, this is the paratracheal avascular plane. Most of the time, see this, that's a carotid artery, deep to the carotid in a horizontal plane. See the vessel coming from deep to, that is the inferior thyroid artery. That is the first structure I always intend to see. First structure I intend to see is the inferior thyroid artery. That's the inferior thyroid artery. Yeah.
Dr. Satish,
yes, sir.
is there any role of thyroglobulin in this case? Because the half thyroid is already removed.
That was not malignant, sir. Malignant would have been a different scenario. Now see, that's the, can you see the artery?
Yes, sir.
Now the advantage of microscopic is, the most important thing to identify are the parathyroids. And parathyroid are so uncertain in place, there is no fixed place for the parathyroids. Their embryonic descent can happen anywhere, right from the, tongue to the mediastinum. Particularly the inferior ones are more notorious. Superior ones are more consistent in their location, final location. But why I have seen the inferior thyroid first? For many reasons. Let me increase the magnification for you to show you something. Can you see the inferior thyroid very clear?
Yes.
In the vicinity of the inferior thyroid, this is inferior, this is superior. The first structure I intend to see, and that is automatically visible, is the recurrent laryngeal nerve. Can you see the nerve?
Yes.
Let me open up this space. Yes. अरे यार क्या कर रहे हो? Can you see the recurrent laryngeal now very clear?
Yes, sir.
If you are in the right plane, you can identify it easily on your own without even looking for it. See the recurrent laryngeal now?
Yes, very clear.
Why you need to look inferiorly? Because inferiorly you get into a common trunk, single trunk. Many a time this nerve bifurcates and it goes towards the thyroid. So always find out this nerve inferiorly. Okay?
Yeah.
Can you see this now?
Yes, yes.
And there is a small branch coming out of it. See this?
Yes, yes.
So as this goes up, it may bifurcate. Now, the most important thing,
Artery.
this is the artery, and now we have to look for the parathyroids. The inferior parathyroids are by and large inferior to it. Superior parathyroids are superior to it. Superior to the inferior thyroid artery. This inferior thyroid artery is the landmark.
Yes,
Inferior parathyroid are mostly inferior to it and superior mostly superior to it. And you know, it is so difficult to identify the parathyroids by and large. And many times this microscopic surgery helps you to identify the vessel which is a branch of inferior thyroid artery going to the thyroid. This is an additional, help most of the time. That's what I am looking at. Is somewhere if I see the gland. One more thing. Most of the time, see, this is the artery. The artery itself is very slender. See this? Artery is not very great, not a big one. I can see some of the branches, but I don't see anyone, going towards a gland. So still I am not sure where the inferior parathyroid is. Yeah, is it? No. Superior parathyroids are always more constant in location. See, this is trachea. This is cricoid cartilage. And yes, I can see the glimpse of superior parathyroids. See this recurrent laryngeal nerve going towards the larynx, the cricotracheal groove. Can you see this? Hello?
Yes, yes.
See the recurrent laryngeal nerve?
Centralized picture.
That's the recurrent laryngeal nerve going up towards the larynx. That is the region of the cricotracheal groove. And here what I see, a very, very important anatomy. Because my goal is to preserve the parathyroids. We don't know what the previous surgeon has done in terms of preserving the parathyroid. Parathyroids are the most important structures and most difficult to identify kind of structures. See how this recurrent is going there?
Yes.
inferior parathyroid I have not yet seen. It's not visible in the usual location. Superior to the inferior thyroid artery, behind the level of the recurrent laryngeal nerve. And what I can see, what I am looking at in the microscope, where the vessels are heading to. See, all these vessels are heading here. And this parathyroid is embedded in the fat most of the time. Yes. Let me show you. Hello.
Yes, sir.
See the vessel going there?
Yes.
That is the fat tissue. And this is the parathyroid which is embedded in. This one is the parathyroid. You see this one? This one is a caramel colored structure. Can you see this one?
Yes.
I don't want to traumatize it. See, if this is traumatized, it will turn jet black. I don't want this to traumatize. If you preserve the parathyroid, this is the parathyroid.
Okay.
The color varies from caramel to brown to yellow from the age, depending upon the age. This is classical parathyroid with a microscope gives you confidence in identify because it has a network of vessels over the surface. See the network of vessels over the surface.
Yes.
And all these vessels are heading from here, heading towards it. And this is the usual location behind the recurrent in the cricotracheal joint. So this is definitely my superior parathyroid. This one, there is no doubt about it. So the location mostly is behind the recurrent laryngeal nerve in the cricotracheal groove. Above is the cricoid, below is the trachea. This is trachea, this is cricoid. And see the number of vessels coming from it. Hello?
Yes, sir.
That is the beauty of microscope, wherein you can see the vessels coming from the inferior thyroid artery. Inferior parathyroid I can't see yet. Inferior parathyroid can be anywhere from its usual location to, anywhere in the, up to the neck, up to the mediastinum.
Yes, sir.
Yeah, it may be in the thyroid capsule, anywhere, you never know. And whenever you suppose you doubt on something like parathyroid may or may not be, this could be also the parathyroid. This could be the tissue. See fat tissue, and this looks like the parathyroid to me. Can you see? But because this is the fat, it is always embedded in the fat. Can you see something embedded in the fat?
Yes.
This one. Can you see this small gland?
Yes, yes.
This one. This could be parathyroid. Now there are difficulties in identifying the parathyroid. The reason being, it could be fat, it could be thyroid tissue itself, it could be lymph node. In case you doubt about the parathyroid and you want to really confirm a transplant, get a frozen section done. If it is parathyroid, mince in small pieces and inject in the muscle in the forearm. To me, most likely this should be from the look, it looks like the parathyroid. See this?
Yes.
Embedded in the fat. Not 100% sure, but this is the location. And this is classically, embedded in the fat. See this?
Yes.
This is a special, not a very, yellow fat. See, this fat is different. This fat, superficial fat is different. Here the fat is different. Even the fat is very, as compared to the other fat is vascular, more network. And this looks like the inferior parathyroid to me, but superior is confirmed, so I will not do anything to it. So we have seen inferior thyroid artery, recurrent laryngeal nerve, the superior parathyroid for sure, inferior parathyroid. This could be inferior parathyroid because I can see a lot of branching vessels over the surface. See the typical color. Can you see very clear or not?
Yes, sir. Centralize the picture. Yes.
This one. And it is still not turned jet black, so I don't want to disturb it anymore. Now another important structure is the external branch of the superior laryngeal nerve. See, this is important to exploit this anatomy and preserve this. Sometime patient, even if this nerve is injured, may get away without any problem, may not complain you. But for the professional voice users, it is very, very important. See what I have done? What I have done? This is the upper pole of the thyroid. See,
Yes.
this is the upper pole.
Yes.
This is superior, this is inferior. See the gland?
Yes, yes.
Now I am retracting the upper pole towards me. This is the midline airway.
Yes.
These are upper pole vessels. This is the strap muscles I am opening. See this?
Yes.
This external laryngeal nerve, it comes from above along the upper pole vessels. These are upper pole vessels. This come along the upper pole vessels, and just before the thyroid, it turns medially to innervate the cortex, cricothyroid muscle, and I can see the glimpse of it. We'll show you. Cerny has devised a classification. Cerny is a head neck surgeon from Brazil, who devised a classification regarding the. Can you see the nerve?
Yes.
See this? This nerve was coming along. See, these are upper pole vessels coming along the vessels, and before reaching the gland, it takes a medial turn to supply the cricothyroid. Can you see this slender nerve?
Yes, yes.
Now this is more than a centimeter above the upper pole. So this is most favorable, you can say. This is most favorable, you can say. If it is within 1 centimeter, it is difficult, and if it is below the level of the upper pole, then it is difficult to identify and preserve. So this is a more favorable condition, and it is because of this the traditional teaching was to clamp the upper pole as close to the gland as possible. Cut, no? Because if you cut the gland as close as possible,
There is
upper pole,
less likely chances.
yeah. See this nerve coming from above.
Yes.
It is a branch of superior laryngeal nerve. See this nerve? See this nerve?
Yes.
And it is taking a medial turn over here. See this nerve taking a medial turn. Very clear. Can you see it or not?
Yes, yes. Very well seen.
So once we have seen this nerve, and this is going to the cricothyroid here. See this very clear, 100% the external branch. This superior laryngeal nerve comes from the upper part of the neck, just below the jugular foramen from vagus. It runs behind the carotid, and here at the level of the thyroid membrane, it divides into external and internal branches. This is the external one, the internal goes through the thyroid membrane to supply the supraglottic larynx, that is sensory branch. And this is the motor nerve, the only tensor, it supplies the only tensor muscle in this region, that is cricothyroid. And see the nerve very clear. Can you see?
Yes, sir. Very clearly.
So now once you have seen the nerve, we can ligate the upper pole away from the nerve. See this? Look at it. Scissors. See, we have ligated the upper pole, preserving this nerve. See, this nerve is there?
Yes.
Ligate. So we have seen the recurrent laryngeal nerve, you have seen?
The external branch of superior laryngeal nerve.
See, that's the recurrent laryngeal nerve. That's the external branch.
Yes.
And these two nerves have 135-degree angle from each other. See this. That is the external branch. That is the external branch, you can see very well. That's the external branch here. That's the recurrent. Both the nerves in one view. Can you see? This is the external branch above.
Yes, sir, yes.
This is the external branch going to the cricothyroid. This is cricothyroid muscle, and this is the recurrent laryngeal nerve.
Sir, for you, the landmark for the recurrent laryngeal nerve is then inferior thyroid artery.
Yes, it is in close proximity to the recurrent inferior thyroid artery once it courses towards the cricothyroid joint.
So you always start with the dissection of the inferior thyroid artery.
Yes, always. So once you see the inferior thyroid artery, you have two compartments now, inferior and superior. In inferior compartment, once you see the inferior thyroid artery, look for the recurrent in the inferior compartment far below, where you find in a common trunk. And see this area where I look for the inferior thyroid artery generally. Once you are in the right paratracheal plane like today, you can see the recurrent laryngeal nerve so easily. Otherwise, in the same triangle, see this triangle is Flores triangle formed by the inferior thyroid itself, the trachea in the midline, and the carotid laterally.
And the recurrent laryngeal nerve is the content of that.
Yes, it's part of this triangle.
Yeah.
Okay? So that is the recurrent, that is my possible,
Inferior parathyroid.
I am quite sure because it is too vascular a region in this region. See this? This is my inferior parathyroid. Superior parathyroid is confirmed here.
Sir,
There's no doubt.
there is a branch from the inferior thyroid which supplies the parathyroid, inferior parathyroid.
Yes, so I don't see here directly. That's why I had a doubt because normally I should have found anterior to the recurrent laryngeal nerve here.
Yes, yes.
So that is the usual location, but I don't see. वो चलाना.
Sir, please tell the boundary George triangle on the superpole.
Yeah, Joll's triangle is what? See this. We have found this nerve here. See this? We have found this nerve over here. So how to find the Joll's triangle? What is Joll's triangle? When you retract the gland towards you, the superior pole vessels on one side, the airway on other side, and it is roofed by the step muscles. You open up the step muscles and you are in the triangle. So that is for external branch.
Branch of the
Yes.
superior laryngeal.
So the best is retract the thyroid towards you. And now once you have seen all the structures, now you can take your, see this?
Sir, some say that use of cautery in close proximity to recurrent is should be avoided.
Yes, a monopolar can damage if you are very close to it. See, but I am not very close. You can see,
Centralize the picture, please.
but I am not very close to it.
We are far away.
Yes, I am doing this under vision. Now I am looking for the paratracheal plane.
Yes.
Here sometimes breast breathing close to the trachea.
This is paratracheal plane. Sometimes you find the inferior thyroid veins here. Might be ligated during previous surgery. See all the structures here.
Yes, sir.
We are leaving behind all the structures. कर दो. See the trachea?
Yes, sir.
That's the pretracheal fascia. This is the isthmus I am removing. The important thing in the thyroid is to preserve all these structures. See once again.
So the whole thyroid is out.
Can you see the recurrent very clear?
Yes.
इसमें करना. See, this is the recurrent laryngeal nerve. This is inferior thyroid artery, which is, taken close to the gland. Can you see?
Yes.
Here superiorly we have seen the external branch. And this is the superior parathyroid, this one. The inferior is a probable one, this one. And see this network of nerves, vessels, everything preserved. So the thyroid surgery involves preservation of these critical structures, particularly parathyroids. You never know how the parathyroids behave sometime. But fortunately, out of all 4 parathyroids, even if one is fully functioning, the patient will not develop, permanent hypocalcemia. May have transient hypocalcemia, temporary hypocalcemia, but not the permanent one. But permanent hypocalcemia is disaster. Disaster. It's worse than the thyroid cancer itself, as patient has a crippling life, with the hypocalcemia for life. So the most important thing in thyroid surgery is to preserve all these functional structures, that is parathyroids, recurrent laryngeal nerve. In case any of these damaged, we should have a plan to restore the function. Like for example, if the parathyroids are gone, devascularize, we should have a frozen section facility to confirm it is parathyroid, devascularize, mince in small pieces and inject in the forearm muscle. Majority of the parathyroid start functioning, whatever implanted parathyroid within 3 weeks. And it has been studied by lots of, studies earlier, that the serum level of the parathyroid starts building up in 3 weeks' time. If the external branch is injured, because that is the tensor muscle of the vocal cord, what you can do then, as the larynx is relaxed, what you can do, take a tough suture at the inferior part of the thyroid cartilage and pull it and suture to the cricoid cartilage, cricothyroid suture.
Can you show us where, sir? Because generally this nerve gets damaged.
I have gloves. Let me show you. So pull the thyroid below to make it tense. So it will help you, to prevent the patient noticing such a deformity, the voice change. But for a professional voice user, if the external branch is gone,
This is the superior base flap. This flap was like this. We have given an incision from this here to this, and going posteriorly, a U-shaped incision for the flap, and we have raised the flap to the superiormost area. So we have already done the welling of this for CI. So we are creating a well. We will be using the nucleus implant. So we have reached the dura.
I think depth is more than enough now, I think.
Suddenly,
Picture is clear?
Suddenly image became very nice. I think now again gone.
Okay.
This is better. Like
Okay.
since morning, this is the first time the image is being so good.
Okay. So to control the bleeding, I am using the diamond burr here. This will be the posterior tympanotomy approach, and shortly Satish will join here. We have already drilled the minute holes for the thread to hold the implant. Picture is clear?
Yes, so out of focus little bit.
Okay, okay. Saline dena.
Now the picture is better.
Okay, okay.
Let it continue in same mode, whichever mode it is.
I am doing the homework for Satish.
The homework is the main thing.
Picture abhi baki hai.
You have to go posteriorly. I think.
Yeah, yeah. So hope people are enjoying the academic.
Many good lectures been done since morning. Dr. Dubey sir, Dr. Umbe Singh, Dr. Kapila.
डॉक्टर सतीश को पूछना आ रहे हैं क्या?
And the child is 4 years?
This is a post-lingual case.
Okay, it is.
This is a post-lingual case, and was using hearing aid initially, but speech was not much developed.
Do you do some evaluation for this post-lingual patient why they developed it, like syndrome?
Actually, the AVT is the main problem, and after hearing aid, the speech therapy is the main problem. So they are not coming regularly for speech therapy after using hearing aid. So this is the main problem, but they were convinced about the cochlear implant, and now the child is having bilateral profound deafness. वो दे देना, सर्जी सेल दे देना, एक छोटा टुकड़ा. सर्जी सेल कहाँ है? छोटा सा टुकड़ा. ड्यूरा हो गया ना? आर्टरी दे लगा. Hello.
Yes, yes.
So what I have learned till now, I am using all the three approaches for doing CI, all the three techniques. Maybe varia, posterior tympanotomy, or modify varia, as Dr. Dubey told us. Uh,
We had a long discussion about.
yeah. So we have already discussed everything. Just polishing the well area with the polishing burr.
It's, I think more than enough. Shining.
So for the information of the audience, there is a small information. We will be having a small inauguration session, and this is just we are having a member from the Haryana Medical Council, and we have been accredited with 4 credit hours till now. We are fighting for further hours, and if they are increased, then we will change the certificate also. But till now, we are having 4 credit hours with us.
Sir,
So
it
we are.
takes a lot of homework to get all this.
Yeah.
Yeah, really great work done by you.
So we are having Dr. Pankaj Mutneja from Panipat. He is the member of Haryana Medical Council, and he will be the witness for this. We have already shared the YouTube links, and he will be there in the inaugural section. It will be around 7:30, and all are requested to be there.
7:30.
Yeah.
You will be here or not?
Me? Me.
So finish it fast. You have opened the asteroid?
No, we are going to
do that part.
Yeah. वो देना जरा कोड हो गया. हाँ गड्ढा भी हो गया. छेदी बना दो. ट्रैक्टर लगा यार. हाँ साइजर हो गया सारा. ये देखो. छेद भी बन गए. बना दिए. ये बना दिए.
Zoom out a little bit.
So Dr. Satish will be joining, and I will start the drilling part, opening the mastoid area. अच्छा चलो ये डाल देता हूँ. So the most difficult part of CI is putting a thread in small holes and tying the implant. So this is the most difficult part here.
So you are still putting the suture?
Yeah. I am saying that I have already told you that I am doing the homework for Satish. नहीं वो दो hook दो. Fine hook. सुन ये वाली ट्रे. So this is the difficult part for me. हाँ वही दो ना, राइट एंगल चाहिए. ये हटाना, रिट्रैक्ट कर, सक्शन कर दे. वो देना, फोर्स से देना. पिक क्या पिक. चलो निकल गया, रहने दे, हो गया. So this was the most difficult part. एक artery दे दो. Picture is clear for you?
Yes, it's very clear. This is microscope picture, huh?
Yeah, this is a microscopic picture. We are using.
Now it's not good. What exactly is going on? Means is
Nothing is going on. We are tying the thread with the artery and.
no picture
this
quality.
Picture quality. Picture
it is
quality को क्या हो गया? यहाँ तो ठीक आ रही
Now
है.
it is better.
आगे सर ना. अब ठीक है?
Now it's okay.
Okay. वो देना जरा. इस पे कुछ रख दो, वो रख दो, सर्जी सेल के पीसेस ना इस पे थोड़ा सा वो कम हो जाएगा. चलो रिट्रैक्टर लगाना यहाँ. बाइपोलर लगी हुई है यहाँ, रिट्रैक्टर लगाना. सो ओपनिंग द मेस्टोइड. कटिंग भर दे दो एक. चलो ज़्यादा सलाइन डालो. Routine approach like we are doing in cortical mastoidectomy. The spine. This is a cellular mastoid, so no problem with drilling part.
The picture quality again deteriorated.
क्या हो गया
It
picture?
was now it's okay. Now it's okay. What is this exactly?
ये क्या हो रहा है?
ये कुछ फोकस का वो हो रहा है फिर से खराब.
Focus issue.
No. Now just changing to the previous mode.
No.
नहीं सर मोड चेंज हो गया फिर से.
Mode change हो गया.
No.
एक मिनट. अब ठीक है?
Now it's okay. Okay. चल जाएगा.
नहीं चलाओ नहीं काम बढ़िया
That's
चलाओ.
okay.
बढ़िया चलाओ यार.
So
ब्लॉक हो गया यार. Yeah. We are having super assistants from the assistants of the Dr. Satish. They are expert and we are thankful to them. They are also our teachers basically. Hanji?
Hello, yes. So now what are the landmarks you will go for, right?
So this is, you have been able to see the short process of the incus. This
Boss,
is
which drill are you using?
this is a Smith nephew drill, Spiegel.
Okay.
So over to Satish now. अरे, वो जो एंट्रोकोनल, हाँ हाँ सर, जस्ट अ मिनट, माइक देते हैं.
Hello.
Yes, yes.
Yes, boss. So we have seen this superb work from
Yeah, ultimate.
boss. So I'll just finish off. Now most of the job has been done. किधर है ये drill? ये किधर? चल तो रही नहीं. Drill. क्या हुआ?
ये वाला पैड है, हाँ. नहीं आपका पीला वाला दबाओ पहले. हाँ, अब चलो. क्या प्रॉब्लम?
Hello.
Yes, yes.
See, let me see what has been done to show you. He has already made the. हाँ कोई बात नहीं. Well for the implant.
Yes, yes.
ये वो उसकी कितना स्पीड कैसे कम है?
Zoom out little bit.
ठीक है रख दे कुछ. ये डायमंड दे दे दो. Give me a diamond. See some bony ooze. And I can always use a diamond. For bony bleeding, you can use either a dry diamond or bone wax.
Bone wax, I think you recommend here in this, I think.
अरे इतना मोटा है, कमाल करता है यार. For soft tissue bleeding, you can use either Surgicel or bipolar.
Yes.
Now this is the gutter for to carry the cable. There are छोटी देना cutting. And see, we need a crude cortical mastectomy, which has already been done. So next is the what we had discussed yesterday in the cadaveric dissection. A posterior tympanotomy.
Yes.
See, this is to complete this gutter. So all the cable and everything remain hidden. And here I will make a little bit overhanging edges to tuck the cable in case required. Because this cable length is always, in children, the mastoid side is not that big, and the cable length is something which expands with time as the size of the mastoid expands. Okay? Now, cutting the body. In the mastoid, you can see the lateral semicircular canal and incus. Can you see?
Sir, can you centralize the picture?
Now?
Yes, sir. So can you show the lateral semicircular canal once again?
Pardon?
Lateral semicircular canal.
Yeah, let me show you.
This one.
That is the lateral semicircular canal. See that?
Yes, sir.
This is the posterior canal wall. Lateral part I'm thinning more and more. The same landmarks we discussed yesterday for the posterior tympanotomy. Remember?
Yes, sir.
That is incus. Short process of incus is one of the best landmark.
Drill along the short process.
Yes, the facial nerve is always deeper to the short process of the incus. See this? I am parallel to the short process of the incus. एक side छोटी. See the short process of the incus in view?
Yes, sir.
In order to enter into the facial recess on a safer note, we are supposed to see the facial nerve medially, and to avoid entry into the canal, extraordinary canal, or injuring the annulus, to stay on the safer side, the best landmark is chorda tympani. These are the two landmarks. If we follow and find, our facial recess is always between this. See the incus, always keep the reference of incus. Can you see?
Yes.
No, sir.
But now,
Yeah.
now visible.
No visible.
Yes. बंद है. I can see some landmarks to show you.
This cell just below the
Cell of the facial recess, yes, is one of the
short
landmarks.
process of incus.
Then I can see both the nerves in view now.
Yes.
Let me show you. I can see the color change, the area of the facial now. Can you see the reddish hue below?
Yes, sir.
Can you?
Yes, sir.
That is facial now. See that?
Yes,
Yes,
yes.
And see that is chorda tympani. Can you see both the nerves?
Yes, sir.
Use the largest possible burr for the region, wherever you are working. That's the basic principle of drilling. For whatever region, wherever you are working,
So you are using the cutting board?
so far. See now, I can see the cell of the facial recess now. छोटा दे.
Yes, sir.
अरे इसको diamond दे दो. इससे एक side छोटी diamond दे. Now we'll change to the diamond and show you further landmarks. This will give us a backdoor entry into the tympanic cavity, retrotympanum. See this?
Yes, sir.
This is a great guide. One of the cell opening is a great guide here. एक side छोटा. Can you see the chorda and facial both?
Yes, sir.
Yes, sir.
Very clear?
Very clear.
And see this facial recess. So clear?
Yes, sir.
And now,
Even we can see the glimpse of starting of the round window niche.
एक side छोटी.
Now the whole round.
Now, yeah, I am removing this bone anterior to the facial now. Anterior thinning of the facial ridge. See this? The glimpse of the round window is visible. See the tendon of stapedius. See this?
Yes, sir. Yes.
Clear.
The same anatomy we saw yesterday. For junior colleague, practice more and more on cadaver. And see the round window.
Yes.
Yes.
Round window membrane is also.
Yeah, little glimpse of it.
Yes.
The niche is there. Let me extend it. Make the use of the entire facial recess. See this? As I am going further, reducing the size of the burr. Can you see?
Yes.
And this is more important, anterior thinning. Deep to the facial now. See this burr you were asking yesterday. See the long tapering burr. Can you see?
Yes.
This is my special, cochlear implant burrs.
So that accidentally your rotating burr should not hurt
Yeah,
the facial.
yes. Now this is your round window niche. धीरे धीरे यार मुझे मत डालो मत डाल See, I am removing the round window niche.
Yes.
And now see the round window membrane.
Yes, very clearly.
See, no time. See the complete membrane. Can you see that?
Yes, sir, clearly.
Now, I told you yesterday, we discussed in detail. If I open up the round window and push my implant, see the direction of the membrane. It is the implant is first going to go and hit the modulus. You saw the modulus yesterday, the entire anatomy. What I want to push my implant in a tunnel. Straight antero-inferior tunnel. Inferior means in the inferior tunnel. You saw the lot of tunnels yesterday. Remember?
Yes, sir.
So what I am removing?
Inferior part of round.
Yeah, the inferior bone adjacent to the round window. That is known as crista. I will not remove the anterior bone. See, remember you saw yesterday what is there anteriorly? Basement membrane. Never ever try to go anterior. You'll end up damaging the basilar membrane, and that is the intracochlear trauma which you don't want. So now, right angle chota. आ गया कन्ना साहब आए ले लिया ऊपर लिया सामान किसी को ले जा साथ आ गया ओह ग्रेट 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 यार आ गया आइडिया तगड़ा था आपका हेलो
Yes, sir.
मत डाल पानी मत डाल धीरे see what in be careful not to go in the medial wall, not to go anteriorly, just inferior widening. See, only inferior widening I am trying to. Steroid. Now, give me the right angle. उसमें लगवा दो ये सामान जो लेके आया ना हाँ लेके आया ना ये लिया है ना अब तो कनेक्टर का चक्कर नहीं रहेगा ना Can you see after removal of the round window? Hello?
Yes, very clearly seen.
What
Even
I
the
will,
blood vessels
yeah,
of the scala tympani is seen.
I will further little bit widen it. पतला दे See, further widening only inferiorly. बंद है यार. Hello?
Yes, sir.
Now see the tunnel. Can you see?
Yes, sir.
Straight
tunnel.
Straight three-dimensional tunnel. I am washing with the steroid solution. That will flush away any bone dust or anything. See this? Never ever damage the medial wall. And see now, this is inferior trajectory.
Yes.
Inferior trajectory means
Scala tympani.
scala tympani. See this?
Yes.
So clear.
Right.
Wash. Wash. Steroid. यही ना? This is steroid wash again. And this is amazing inferior tunnel. See this? Now, if I push my implant, see my modulus is left, on the left side. See
Centralize
that?
the picture.
See the modulus is on the left side.
Yes, yes.
Can you see?
Yes, sir.
Here is the modulus. See here. And my direction of the implant would be this. Can you see straight tunnel?
Yes, we can see.
So my modulus is now left behind on the left side. No, gel form. And now I have the implant insertion will be a child's play. It will go in the straight tunnel, nowhere else. Got my point?
Yes.
It will not hit modulus, it will inferiorly directed, it will not hit the osseous spiral lamella. That is what the message I wanted to convey to understand the inner ear anatomy. We have seen inner ear anatomy yesterday, how the cochlea is, made up of, how the cochlea is oriented. Steroid. I have pushed the gel form, soaked in steroid. Leave it for a while until I fix the implant. Okay? Hello?
Yes, sir.
Now I will harvest two things. Cutting the bonus liya? Already harvested or periosteum? No, give me something to harvest periosteum. We have already harvested bone dust. And now I need to harvest some periosteum. तो इधर this is periosteum. See this? This is a tough tissue which we want. That's it. Could you see?
Yes.
Now before I insert my implant, एक वो देना वो तो कॉटन अंदर रखने को गॉस पीस देते छोटा I will thoroughly wash, irrigate, see if any
Bone dust.
See if any bleeding or anything there. Before I open the implant, I have to achieve the hemostasis so I can switch off the cautery. Though it doesn't affect much, but still we have to diamond देना छोटी. Follow the manufacturer's instructions. It can affect the electrode's integrity, the electrical field generated by the cautery. Bipolar. किधर है? ये क्या? चलो 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 डाल See, you have to achieve complete hemostasis. Watch with that.
Excuse me, sir. Can we use the bipolar cautery after we put in the implant?
Yes, you can. Even the monopolar doesn't affect much. So many studies done. But since, see, anything goes wrong, If you don't follow the manufacturer's instruction, they may not reimburse.
Okay, sir.
Why to take chance? Spend 1 minute extra, achieve hemostasis, and then go. Yeah, wash. मेरे को दे wash. I will flush away all bone. नहीं नहीं ये नहीं. Implant. See the field?
Excuse me, sir.
Yes, please.
Let's say, sir, in a cochlear implant patient in future requires another surgery like an abdominal surgery. And
Yes.
if they use bipolar cautery over
Yeah,
there,
can use. See,
monopolar.
the cautery has been considered safe to use, even the monopolar.
okay,
It
sir.
has been, but you have to respect the manufacturers, But generally, it doesn't affect.
Okay, sir.
अभी है ठीक मैं कैसा हूँ केस ले रहे ना उसके बाद थायरोग्लोस पक्का नहीं मेरे को कोई दिक्कत नहीं See this? The tie down holes made by Dr. Khanna. See, this is the best way of fixation. I would say most certain way. You can make a periosteal pocket also. But see, implant migration is a disaster. One should never take a chance of implant migration. Everything, whatever good work you have done can be ruined. इधर करना है इधर मार So implant migration should not happen. You should rigidly fix it onto the bone. See this?
Yes. So this is proline.
Yes, most likely proline है ना भाई. This is ethylone. What I will do, I will invert the edges of the ethylone. See this? They should not come in contact with the skin, otherwise they may perforate and invite infection. See this? These are completely fixed. This Surgicel will invite fibrosis over here, and the proline edges will not come out. See this?
Yes.
Now, over there now, periosteum elevator. This is the ground electrode, forceps there. You will forceps. Yeah. This is the ground electrode, which is going to go underneath the temporalis. See this? See this?
Yes.
And now finally, the electrode insertion, and believe me, that is the simplest of the entire steps. Once you have created this tunnel, wash. The electrode insertion is the simplest of all the steps. नहीं वो दे. See, the last thing is electrode insertion. And that will be child's play, because now you have to insert in a straight tunnel without any hindrance. Forceps. I am removing this gel form. वो दे दूसरे वाला. हाँ हाँ आराम से. See, we'll flush it again. See the tunnel?
Yes.
See the tunnel, and now direction of implantation is in the direction of the tunnel. See this?
Yes.
What are the forceps? वो देना यार with the forceps. And the last part now is the implant insertion. See the implant? See the electrode array? There's a straight one.
Yes.
See the direction? See, it has to go along the floor. Can you see the direction?
Yes, yes.
Inferiorly directed in the lower tunnel. In the lower tunnel, without any resistance at all, you can feel. See this?
Yes.
I can see no resistance there.
We can also feel.
Yes. This feeling is very important, you know. Once you feel the resistance, my all electrodes are in. See this?
Yes.
Give me the,
Tissue seal.
yes, tissue seal. Once you feel the resistance, you are supposed to stop over there.
Sir, is there any time period like for 1 or 2 minutes
Yeah,
required for insertion of the
It has always been, advocated to insert slowly, 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 so that you don't damage anything. You don't push on the obstruction. That is the whole idea. The whole idea is straight.
Don't push when you feel resistance.
Yeah, what is straight, yeah, right angle. nahi.
Should be smooth insertion.
And now I will see my periosteum coming all around. Can you see snugly fitting?
Yes.
Gel form.
And the excess electrode is also, you have made enough space for them. It will
Yes.
be accommodated immediately.
Yes. So this see this fixation, sealing of the round window, this round window and the cochleostomy is very, very important. Because
movement.
that is otherwise the avenue for infection to go inside. Otherwise,
What he is giving you?
this is gel form.
Gel form, okay.
Gel form swells up more than its volume and keeps the things in place.
Sir, this implant is fitting, going inside the bone of this length only, not more, like the processor unit.
Pardon?
सर जो वेल आपने ड्रिल की है और उसमें जो फिट हुआ है इंस्ट्रूमेंट, तो उसकी और डेप्थ नहीं जाएगी, इसमें इतना ही रहता है, लाइक सम आर गोइंग इनसाइड.
No. See, the length of the implant is 24 millimeter.
आई एम नॉट टॉकिंग, सर इम्प्लांट का ठीक है, ये जो वेल बनाया है उससे ऐसे प्रोट्रूडिंग ज़्यादा लग रहा है एक्चुअली.
This is not protruding. See this one?
यस सर.
Yeah. So the implant base is inside that.
ओके.
This is the small protrusion which is going to remain. This is less than 4 millimeter.
ओके.
The punched out thing which is there below the implant, it was into the bone.
Can you see now everything fixed?
Yes.
Cochleostomy fixed. See this implant is fixed. Not the bone. Now, see the study is very interesting. When the mastoid expands, your electrode array is going to expand. Got my point?
Yes.
But it has been proven that the distance between the round window and this facial recess edge never expands.
Wow.
Again, what I'm trying to say, the distance between round window and the facial recess edge
Not changed.
never expands in life. Whatever the mastoid size can grow, your electrode can uncurl whatever it is placed in the mastoid.
But not the electrode area which is inside the cochlea.
Inside the cochlea and outside the cochlea till,
Facial recess.
yes, yes. So I don't want that to be my electrode to come out after that, so putting some bone dust there. See this?
Okay.
This is so important to prevent electrode mobilization. Got my point?
Yes.
See, so tightly packed and it will become a bone. Now, I told you to keep the little overhanging to keep my electrode array curled. Can you see?
But suppose you have to do any revision in future, then this bone dust.
You can drill away. You can drill away.
So, boss, in the revision surgeries, due to this bone dust, the electrode will not come out of it. on
So
itself.
why you are doing revision surgery to remove the electrode only?
So we don't know, there can be any reason, but
Yeah. So then you need right angle. You need to remove the electrode. And see, my part of the facial recess is visible. Can you see?
yes.
I will make it little more visible because there I don't need a bone dust. There I don't. I need bone dust here only. See this?
Ultimate.
And it works so well. This we now do in almost every case. It works very well. See now, my electrode is, the implant is in place. This is the ground electrode curl, and the entire electrode array inside the cochlea. What do you see? So smooth the insertion in the inferior tunnel, directing right inferiorly into the tunnel towards the modulus. So that removal of the cresta, the inferior edge of the round window, has changed the entire game. Otherwise, had I pushed the implant, it would first go and hit the modulus, then it would curl inside, and see how thin the osseous spiral lamella is. You have seen yesterday. So flimsy, so thin bone.
Even this is the most common cause of tip rollover, boss.
Yes,
in
yes.
electrode.
If you go and hit some wall, what is going to happen? Now we have our audiologist. We can move on. Madam, can you give? Bhai, gloves. So we'll check the impedance and NRT and all that. Any questions regarding this? Any suggestions or any different method of,
No, I think most of us are using same way, and wonderful. ART, NRT is done.
No, they're doing.
I think the most important part is to send the electrode into the scala tympani, and for which you have taught us sure and short method.
Good. So the impedance is good. We have checked all electrodes.
Very good.
Sir, would like to see the flap, U-shaped flap, how much it is covering.
Pardon?
So the flap, mucoperiostral flap, you have retracted.
That will cover everything, because once we raise the flap, that time the tissue retracts. So it is always our policy to do some sort of undermining of the tissues
So
in
you
the
have
beginning.
already done that.
In the beginning of the surgery, so that it doesn't fall short. Because now after implanting, we don't want to do any undermining, any bleeding or anything.
Very low impedance, it means very smooth insertion. Super.
So it was a smooth insertion because it was in the straight, tunnel.
Yes.
It was a child's play. Simple removal of the crista has changed the entire scenario. Just removal of the crista because now you have a straight shot tunnel, straight shot insertion. It is not blind insertion. The movement, first 8 to 10 millimeters, which you see directly in the tunnel, if it goes along the floor, straight under vision, it is going to curl inside the cochlea on its own automatically. The moment it starts hitting at the beginning, it is going to hit again and again.
Right.
And osseous spiral lamella is so flimsy, so fragile, the moment it hits, it fractures, and that is the highest level of intracranial